Hello, everyone. On behalf of Amyloidosis Support Groups, we want to welcome you to our ATTR webinar. We're hoping to resume live meetings one day, maybe in fall, maybe early next year. Stay tuned to our website, our Facebook groups, and our e-blasts, and One Amyloidosis Voice to find out when that will exactly be. Fingers crossed on that, right? Okay. You'll be able to hear the responses from questions that you emailed in prior to this event, okay? You will not be able to type in questions on the bottom of the screen. The chat is going to be for Paula and other people posting important comments and links. If you do have a question that arises during the event that was not emailed in, you can email one to me at info@amyloidosissupport.org, and we'll try to get that answered at the end of the program if we have any time. Okay. In the control room today, we have our executive director, Paula Schmitt.
Hi, everybody.
Okay. And our special projects director, Bob Gibson.
Good afternoon, everybody.
We almost thought that Bob Gibson was a dog there for a second. We heard the barking.
Yeah, he's in the background.
Many of your, okay. Our presenters today are Dr. Matt Maurer, brilliant cardiologist from Columbia University. And also joining him today are two other brilliant cardiologists, Dr. Nitasha Sarswat from the University of Chicago and Dr. Lynn Punnoose from Vanderbilt. Our brilliant neurologist today is Dr. Sami Khella from the University of Pennsylvania. Okay. We'll also hear from Intellia's Maitland and Alnylam's Colleen Moffitt. From Ionis, Gustavo Bichel. Two people from Pfizer today, Lori Baylor and Abbas Ibrahim. And last but not least, Spencer Guthrie from Atralis. There will be a quick survey when this meeting is over, and we ask that you please take the time to fill it out. It's really important because it helps us when we develop future webinars, and we do listen to everything that you say. We'll be referencing various treatments today, and they can be seen on our treatment chart. Bob will put it up there so you can see that. But you don't have to take a picture of it or print it on your screen unless you want to. The chart's important because you don't have to worry about how do I spell that or how do I spell this. You can go to a Google link that Paula is going to post in our chat to see that chart as well, or you can email me at muriel@amyloidosissupport.org for a copy later on. Before we hear from our guest, Paula Schmitt, our executive director, has a few words for you. Paula?
Hi again. The ASG recently took part in a study concerning our patients diagnosed with ATTR amyloidosis, and the subject of sleep apnea came up. And because of this, we want to run a quick poll for the patients only, please, to see how many of you actually have been diagnosed with sleep apnea. And we're going to put the poll up, and there are 3 different questions on there for the 3 different types of patients that we're trying to get information from. We have a question for the wild type patients, one for hereditary TTR patients that are active in their diagnosis, and then another question for patients that have the gene but are not active in the disease yet. So if we could please put the poll up. Okay, so 16 out of 53 with wild type said yes, 37 said no. 12 hereditary patients that are active said yes, 41% no, and 2 that are carriers said yes, and the remainder said no. So thank you all very much for those answers. That will help us answer the question that went along with the other study that we're working on. Appreciate it.
Thank you. And thank you, Paula. And thank you, everyone that took part in that. It's non-scientific, we know. Okay. Now, what you've been waiting for, or who you've been waiting for, Dr. Maurer. Dr. Maurer, take it away.
Thanks, everybody, for having me. And thanks to Muriel and the team, Bob, and everybody for setting up what is always an amazing experience. And it's a pleasure to be with everyone. I hope you can see my slides. So thanks for the invitation to speak to you today. These are my disclosures. Our laboratory and research is supported by the government and several pharmaceutical companies. And everyone knows me. I couldn't give a talk if I didn't mention that I think the cost of drugs for patients with amyloid is too high. Patients can't afford the drugs, they don't take them. And if you don't take the drugs, they don't work. So that's something we all need to work upon. Many of you know a lot of this information, but I just wanted to review. So we're talking today about a disease called systemic amyloidosis, in particular TTR. Amyloid, as you know, is a disorder of an extracellular deposit of a protein, and the protein get deposited in various organs throughout the body that interfere with the structure and the function of those organs. While there are many proteins in the body that can form amyloid inside the body, at least with regard to us cardiologists, who I always jokingly say aren't too bright, there are really two main proteins that we worry about, and that is AL amyloid, which we're not talking about today, associated with a plasma cell dyscrasia, or transthyretin amyloid that could either occur as a variant in which there's a single point mutation in the TTR gene, or as what we used to call senile cardiac amyloid, abbreviated SCA, or wild type disease, which there's a normal TTR gene sequence and no variant or mutation. So just some terminology, sometimes it gets confusing. Amyloid is the term that refers to the protein deposits. They appear like starch, hence the term amyloid. And amyloids are aggregates of proteins that become folded into shapes that allow many copies of that protein to stick together in forming the fibrils. But amyloidosis is really the disease that results from the deposits of the fibrils. So a slight distinction, but an important one. I thought I would spend a little bit of time just today reminding everyone about how proteins are produced. And so I'll show these series of a few videos and how amyloid develops, which I think are helpful and illustrative. So this is how we synthesize proteins in the body. In this video, you'll see inside a cell, or the nucleus, there is your DNA, and your DNA can come unraveled, at which point in time you transcribe or copy the DNA into what we call messenger RNA. And the messenger RNA leaves the cell going out into the outside, and it gets taken up by things called ribosomes that are going to transcribe from the mRNA the actual proteins. And as you can see, every 3 letters of DNA gives you a particular amino acid, one of 20 that are formed. And this process goes on as we produce proteins consistently. And then as time passes and the protein is rapidly produced, there is what's called a kind of a stop codon that tells one that the protein is now completely produced. And so that is the primary structure of the protein. That is the amino acid sequence. So the folding of proteins is kind of an amazing biological process, remarkably efficient. All proteins need to be converted really into tightly folded compact structures in order to function appropriately. And a single simple protein has 10 to the 16th possible configurations that it can end up in. And so if you think about that, billions, if not trillions of different ways a single protein can fold, it's kind of a testament, I would say, to the power of biology that most proteins fold appropriately. And this video will describe some aspects of how proteins link together and work.
Proteins are polymers constructed from the same set of 20 different amino acids. The primary structure is the specific sequence of amino acids specified by the gene. In the secondary structure, portions of the protein begin to coil and fold into unique three-dimensional formations. Two kinds of secondary structure units are the alpha helix and the beta-pleated sheet. The folds and coils of the protein are the result of hydrogen bonds that occur at regular intervals. The tertiary structure is formed by interactions between side chains of various amino acids. At this stage, some proteins are complete. Other proteins incorporate multiple polypeptide subunits, creating what is known as the quaternary structure.
And actually, transthyretin, as we'll see, shown here, has a quaternary structure. So the protein that we're talking about this morning that causes TTR amyloid is what we describe as a homotetramer, or a four-leaf-like protein in which every single monomer, shown here in green, red, yellow, and blue, link together as a four-leaf-like clover. And the disease develops as the protein dissociates into small pieces, what we call monomers, and those monomers form the amyloid fibrils. And amyloid fibrils can deposit predominantly in this disorder in the heart or the nerves, leading to the phenotype that we describe as either cardiomyopathy or polyneuropathy. So I'll just give you one last cartoon that will demonstrate how a protein like transthyretin can aggregate together these monomers and form the amyloid fibrils. You can see here's a protein that's trying to fold in its normal and appropriate shape. And typically the beta-pleated sheet structure can align, and you can see over here there's a lining up of proteins running back and forth, kind of a coil. And this particular single monomer can then link together with another monomer, which will be shown right now, and then another one, and another, and they aggregate quite quickly, lining up to form ultimately the amyloid fibrils. And so this is the mechanism by which protein misfolding leads to the generation of amyloid. It's critically important in all forms of amyloid to make sure that you know what the precursor protein is. I assume everyone on this call has been appropriately diagnosed and has, again, TTR amyloid, a protein produced by the liver as a tetramer that dissociates into monomers and forms the fibrils. And the reason that this is important to distinguish which form of amyloid one has is because obviously the precursor protein differs and the biology of the disease, but so does the natural history, the genetics, and the treatment. I'm going to spend a few minutes talking a little bit about this concept of ejection fraction, which is often used by cardiologists to determine cardiac function and try to elucidate to you why ejection fraction in amyloid is not a very good measure. So ejection fraction is simply the measure of how much the heart pumps every beat, volume of blood, over how much the heart holds. And so in a normal heart, you can see here, this is the muscle relaxed at end diastole when the heart is completely filled. It contracts and it ejects downward and thickens. And you can see that a normal heart would hold on average 100 milliliters of blood when it's relaxed, and it might hold 30 milliliters of blood when it's done pumping. It doesn't completely empty. And so 100 minus 30 is 70. That is the stroke volume, the amount that the heart is pumping. And if you divide that by 100, you get the ejection fraction. In amyloid heart disease, the heart is much thicker, has trouble filling. And as a result, the capacitance, or the amount of blood inside the heart, is reduced. And the heart's still quite a good pump. It contracts very well, often down to a very small volume. And so in this example, the heart might start with only 50 milliliters of blood, end up with 15 milliliters of blood, and as a result, pump 35, but when divided by what it holds, the ejection fraction is still, quote unquote, preserved, or in this case, normal. So you can see that there's been marked structural changes to the heart, but unfortunately, the ejection fraction doesn't reflect that. An alternative way to think about the heart is what we call the cardiac output. That is demonstrated here. That is, the cardiac output equals the heart rate, how fast your heart is beating, times the stroke volume. That is how much blood the heart pumps each beat. And so in the example I gave, if the heart goes 70 times a minute, and as you saw, normally pumps 70 mLs, it would pump about 4,900 milliliters a minute, which is approximately 5 liters of blood every minute. In amyloid heart disease, in the example I gave, the cardiac output would be, say, would pump only 35 mLs. And often the heart likes to go faster and quicker. Say, in this case, we're giving an example of 100 beats a minute. And so it would pump 3,500 milliliters or only 3.5 liters a minute. So as you can see, ejection fraction in the previous slide was preserved or normal, but unfortunately, cardiac output could still be impaired. And that's why ejection fraction is not a good measure to determine how well the heart is working in patients with cardiac amyloidosis. If you understand the biology of the disease, in which, again, the protein that we're talking about, transthyretin, is made in the liver as tetramer, goes into the bloodstream, and can, in the setting of either aging or various mutations, become unstable and form these folded monomers that deposit in the organs, you can then understand potentially emerging therapeutic strategies to treat this condition. First is the idea of knocking down or silencing the production of TTR. That can be done with antisense or small interfering RNA, or maybe even CRISPR-based therapy. There are drugs to stabilize a transthyretin to prevent it from dissociating into monomers. That includes tafamidis or diflunisal or maybe acoramidis. And then there are anti-amyloid therapies, including PRX-004, NI-006, and AT-03 therapies that are being developed to extract amyloid from pre-existing tissues, including the heart. Muriel has provided this slide to everyone, and it highlights the various therapies that are either approved. In this case, you can see mainly just tafamidis, patisiran, and inotersen shown in black. One is a stabilizer, and two are silencing or knockdown therapies. We can talk and answer hopefully questions about how each of these may work and what their role is in the therapeutic strategy and treatment of individual patients. I give you a cartoon here, just again describing how drugs that are stabilizers would work, in which you can see there are small ligands shown in green that basically bind in the intercalated spaces of the protein, preventing the protein from dissociating into the regulated monomers that can then form amyloid fibrils. And this is the primary mechanism of TTR stabilizers. The therapeutic idea behind small interfering RNA or antisense or oligonucleotides is shown here. We can have a small piece of either RNA or DNA that is administered. It is targeting, in this case, the hepatocyte or liver cell, and it is delivered, taken up inside the liver cell, and literally silences the production of the protein of interest here, namely TTR. And the hypothesis behind these therapies is shown here, in which you are making a abnormal protein, be it variant or wild type. It becomes unstable, it deposits in the organ and causes the phenotype. And by blocking the production, we can reduce the unstable circulating pieces, prevent the organ deposition, maybe even to potentially clear it, hopefully stabilize and maybe even recover organ function with these particular therapies. Finally, there is in the silencing realm much excitement about this idea of what we call CRISPR-Cas9. This is a gene editing approach in which a lipid nanoparticle, small lipid, is laden inside of it with a particular TTR specific guide, and this gene editing structure that was awarded the Nobel Prize just a few years ago that can literally silence the production of various genes and hence reduce the production of proteins in the body. This is administered as a single IV infusion. The substance is taken up by the hepatocytes and causes transthyretin to no longer be produced, whether you're making a normal transthyretin or a variant one. Finally, there are anti-amyloid therapies. The one that's furthest along used to be called PRX-004. Novo Nordisk just recently purchased this compound and planning a phase 2 trial. But the general idea of all anti-amyloid therapies is shown here, in which in particular, you're trying to target little spots, if you will, on these misfolded monomers or soluble aggregates that are not available to be seen in the normal tetramer. So these antibodies bind, if you will, to either preformed amyloid fibrils or to free soluble monomers, and can lead to activation of macrophages that can work toward removing amyloid from tissues. And by binding the oligomers, you may prevent new amyloid deposits as well. So I'll conclude there. I'm happy to take any questions, as I'm sure my other colleagues are as well.
Thank you so much, Dr. Maurer. We really appreciate that. And if we could have all of our panelists, Dr. Khella, Dr. Sarswat, and Dr. Punnoose, put your videos on and get ready to answer some questions, because we're not going to leave it just to Dr. Maurer to answer these. There's quite a few of them. Okay, we'll take a few now. Okay, this person asked something that we hear all the time. What about exercise and diet? Is there anything that's especially good for people with TTR amyloid, or anything horribly bad? We know sodium is a bad one, but something other than that that's good or bad. So we'll start with Dr. Maurer, and then we'll move down the line.
Yeah, I think exercise is highly underappreciated as a important therapeutic intervention for all forms of cardiovascular disease, and especially patients with amyloid. What I typically describe to patients is, even if, God forbid, your heart is not functioning well, you can strengthen your skeletal muscles, your blood vessels, and other things. The analogy I would give is, if you're a student and you had bad vision, couldn't see the blackboard, the teacher would compensate and move you to the front of the room. That's what I think exercise does. It improves lots of other aspects, not only of cardiac function, but of functional capacity. Actually improves your mood, and I would strongly encourage people to stay as active as possible. Regarding diet, I agree, salt restriction is sometimes debated, but is usually quite important, especially in patients who have heart failure with amyloid. People often ask about eating too much protein. That's a common question, and I don't know of any evidence that eating too much protein is something that promotes the development of amyloid, so I don't recommend people restrict protein intake.
Okay, Dr. Khella, what do you have to add?
So I agree absolutely with Dr. Maurer about exercise. I think exercise as much as you're able to do, and you don't have to flog yourself, but it makes you feel good to be able to move around. Now, people with a neuropathy, the thing that in terms of the diet, and I'll talk about neuropathy in a little bit, but there are some things that you need to be careful about in terms of too much vitamin B6, for example, is bad for the neuropathy. And so having a balanced diet is really good for your neuropathy. And I'll talk about neuropathies in a little bit.
Okay, great. And Dr. Sarswat, do you have anything to add to that?
No, I mean, I think I agree with everything that's been said. I think, it's been shown time and time again in the heart failure literature that exercise only strengthens the heart. And I think it's wonderful. And I think people always ask, is there a limit to what I'm supposed to do? Should I not do too much? And I think there's a lot to be said about using common sense and, trying to exercise several times a week, use those skeletal muscles, try to improve your respiratory status that way too. In terms of diet, I think what everybody else said, I feel like I see patients with amyloid time and time again that are losing losing muscle mass. And I think the protein can be really helpful in terms of maintaining muscle mass, and then fluid and sodium restriction beyond that.
And Dr. Punnoose?
Same things as what the rest of my colleagues have said. I think exercise, therapy, physical therapy, rehab are all good things for the heart. It's good for heart failure. And especially with diet, the same things folks have mentioned so far. Paying attention to fluid intake and salt intake are good. Okay,
thank you. Okay, next question. Okay, this wild type, I'm a male, and he mentions his ejection fraction. I know Dr. Maurer just did part of the presentation on it, but he says his ejection fraction is 24%, which doesn't sound really good to layman Muriel. He says he's too old for either a heart transplant or open heart surgery. And he wants to know what else might be available to him. And he also asked, is there an external pump that can assist his heart in producing a greater supply of oxygenated blood? So Dr. Punnoose, since we have you here, we'll ask you, and then we'll go to the others.
So from what I understand of the question, Muriel, some of the questions is in terms of managing heart failure. Is that accurate to say?
I would guess, yes.
Yeah. And I think, again, paying attention to what we mentioned before is going to be important. I understand part of the concern that the question had expressed is about him not being a candidate for advanced therapies like transplant. In terms of things like mechanical pump, a lot of us pay attention to that in terms of how the heart's doing, even though his heart function is low. Many times, because of the way amyloid affects the heart and the heart chambers, mechanical pumps are not really ideal for that. And so we would focus a lot more on treatment of the heart failure with medicines, and then consider the therapies that Dr. Maurer just reviewed as well.
Thank you. Dr. Maurer?
Yeah, I mean, the question about ejection fraction, I think, is important. So what I wanted to imply was that, you know, when your EF is normal, don't assume everything's A-OK. But in this particular circumstance, a low ejection fraction is unfortunately a marker of pretty advanced disease in patients with all forms of cardiac amyloid. Remember, the heart, as I showed, is really tiny and small. So the reason you can't biologically fit one of these pumps in, which we do use for patients who have very large and dilated hearts, as often occurs in the setting of a heart attack, is because, you know, it's anatomically very difficult to fit the pump in. People have tried, you know, and the data is not very favorable. And so I think sometimes you think you're missing out on things, but I would say that, you know, avoiding an LVAD in amyloid is probably ultimately a good idea. To be a little provocative, I think most standard medical therapies for heart failure aren't that effective in patients with amyloid, besides, you know, usual diuretics, particularly a drug called spironolactone. It's pretty old, has been recently shown to be effective. I think the jury's out on some new therapies that are particularly hot in the cardiac arena, and that is what's called SGLT2 antagonists. These are new drugs that were originally developed to treat diabetes that have been shown across the spectrum of cardiovascular disease to be very favorable. They're empagliflozin and dapagliflozin are the name of the two of the ones that typically are used. And I don't know, they may have some clinical benefits. We'll have to see in patients with amyloid heart disease. So I would encourage whoever this patient is to speak with their doctors about, as people were saying, you know, additional medical therapy.
Great. To Dr. Khella, Dr. Sarswat, anything to add to that?
Sure, I'll add a couple of things. So, I mean, I agree with what everybody said about mechanical support in terms of our left ventricular assist devices. I think it's rare that patients with amyloid, that the heart dilates out enough that they can support an LVAD. There are rare instances where the heart dilates out enough that it's worth thinking about. I think that there is a push in the community and certainly a lot of discussion about designing a different type of heart pump that would target the atria of the heart rather than the ventricles, which we know are dilated in patients with amyloid. And I hope that eventually will become a reality for our patients. In terms of medications, you know, I think what Dr. Maurer said about SGLT2s is absolutely on point. In general, I feel like most of our amyloid patients do not tolerate our standard medication for heart failure with a low ejection fraction, our beta blockers, Entresto, things like that. And we end up actually pulling those away instead of adding those medications. And, you know, in the data that we've seen, there has not been the same benefit despite the low ejection fraction for patients with amyloid that we see in other patients with low ejection fractions.
Okay, anything to add to that? And next, here's a question for all of you. And this comes up in our Facebook group all the time. The combination of using Onpattro or Tegsedi with Vindamax or Vindical or whatever. So this person's question is, I've been on Onpattro for 4 years. It may be slowing the progression, but it is not stopping it. Okay. My 6-month echo was slightly worse than the previous one. My doctors think my best chance for survival is to add Vindamax. So obviously we have a hereditary person if they're on Onpattro for neuropathy, okay? I do not qualify for financial assistance. That's okay. I just got my monthly supply and I admit that the price tag is causing some significant stress. Well, we know that's going to be a factor for sure. But getting back to the combination of Onpattro and Vindamax, Dr. Sarswat, you're on the screen. Do you have patients on both? And what is your feeling about being on both? I know there have been no studies about it, so I'm eager to hear.
I do have patients on both. I think, as you alluded to, insurance and pricing can be something that prevents us from getting a lot of people on both. But I do feel like, stabilizers and our silencers work differently, and that they can potentially work well in combination to attack the disease in different places. I think that there is a point where perhaps there's a saturation point where if you're not making a ton of the protein, what is there left to stabilize, and where that kind of saturation point is, we don't understand yet. I'm looking forward to a lot of the data that we're going to get from these most recent clinical trials, where we're actually able to see what happens to patients that are on both types of therapy. And I hope that will bring some clarity and safety data as well to the dual therapy.
Okay, Dr. Maurer, what about you with both drugs on we'll say on Patro, but this could be also Tegsedi and Vindamax. What are your thoughts on that, Dr. Maurer?
Yeah, I completely agree with Nitasha. I have a handful of people on both. I anxiously await the results of some trials. I think we'll learn from, for example, Apollo B later this year, which is a randomized trial of patisiran versus placebo in patients with cardiac disease, both wild type and hereditary, of which about a third of the patients were also on tafamidis, whether or not the combination is better. So stay tuned. I would say that in general, when I'm adding a stabilizer to a silencer, I often add diflunisal to start, and the patients, the handful that I've had who are on tafamidis are people who for some reason couldn't tolerate usually diflunisal. So the cost issues are pretty small there. My sense is it's very well tolerated in patients who have neuropathic disease.
Okay, before I go on to the other physicians and their input on the two drugs together, Dr. Moore, you said you sometimes will have them do diflunisal, obviously for cost benefit, but do you feel that diflunisal and Vindamax or Vyndaqel are equal in effectiveness?
We don't know, so kind of irrelevant what I feel. I would say that the biochemical data suggests Vindamax is a better stabilizer, but practically it's not something that I think we have really good data for. There have been single center studies. We published one, Cleveland Clinic and others. There's recent data from the BU Center describing that diflunisal is got some clear saltatory benefits and may be a reasonable alternative, especially in individuals who are struggling with cost, assuming again you can tolerate any of the potential side effects. I would remind everyone the dose of diflunisal that we're prescribing is 250 milligrams twice a day, which is below the starting dose for quote unquote treatment of pain, the non-steroidal dose. So concerns about the non-steroidal side effects, God forbid, kidney insufficiency, GI bleeding when you're on another blood thinner, probably are, I think, overrated, though we have to be careful because individuals with advanced heart failure who are on high dose diuretics, God forbid, have more than, I'd say, class 3 symptoms or class 3 or greater. They may not tolerate diflunisal. Having said all that, if you don't tolerate it, the side effects usually are not permanent. It can be stopped and people reverse. So it's something that we do offer patients quite a bit. The other group we offer, I just would mention, is allele carriers of a variant who don't yet have a phenotype. So people who want to potentially prevent the development of disease, you're not going to be prescribed any of these therapies because you don't have disease yet. And diflunisal may be an option to, we think, prevent development of disease, though we don't have data for that either.
So you sometimes will put a patient who has a certain variant in their family, and and their DNA showed that tests showed that they have that variant, but they're not yet symptomatic. So you would give them diflunisal as a prophylactic, so to speak.
Yeah, and we have conversations about that. Obviously, taking a non-steroidal for 15 or 20 or 25 years, God forbid, when you may never develop disease, that's a difficult decision. So in general, we have conversations with each individual patient. We look at when their, God forbid, mom or dad or loved one had disease, and are they approaching that age range, and do they want to take the risks and the benefits of potentially taking Dolabit. But that's the two big groups. Almost everyone we have on Onpattro is also at our center, often on diflunisal. And the other group that we talk about is these carriers who are approaching the age when the so-called proband, their loved one, had disease.
Okay, and Dr. Khella, where are you on both drugs?
Right, thank you. So I agree with everything that's been said so far. I would say that, diflunisal, there is data for both tafamidis and diflunisal for improving the neuropathy, especially the very mild and early neuropathy. And like Dr. Maurer, we prescribe it to patients who may be carriers. And again, it's a conversation with each individual patient who doesn't have the disease. But certainly we give dual therapy to many patients. And it seems to be well tolerated, whether it's tafamidis or diflunisal and a silencer like Onpattro or Tegsedi, because they do help the neuropathy, even if they have a very mild early neuropathy, or especially if they have an early and mild neuropathy.
Okay, thank you. And Dr. Punnoose?
Nothing new to add compared to what others have said. We do have patients on both, and I'm looking forward to seeing more about the data coming through.
Okay, great. And does anyone want to add a few more words to this before we go to the next? Oh, you know what? We really should. Well, we could go on forever on this, and we will take more questions. I promise you. I have a stack of them here. But next up, we will go to our neuropathy presentation with Dr. Sami Khella. So, Dr. Khella, take it away.
Thank you. And it's a hard act to follow Dr. Maurer because he has nice slides and he talks about the heart, which is a very sexy thing. But I'm going to talk about peripheral nerves and the neuropathy. I don't have any slides, so I'm just going to wave my hands around, which is what I normally do. A neuropathy, I want everybody to understand, is the wires of the body that are affected. And so the wires that I'm talking about are the ones that feel things in your hands and in your feet, and also the ones that go to your muscles and make your muscles work. Those are the peripheral nerves. There is another kind of nervous system which is also affected in amyloidosis, and that's the autonomic nervous system. That's the kind that it's autonomic. You can think of it almost like automatic. You don't think about it. You can't control it. It's what controls your digestive tract. It's what controls the blood vessels so that when you stand up, you get lightheaded or you don't get lightheaded, depending on the problem, if you have a problem. And so that's the autonomic nervous system. And both of those systems are affected in amyloid. And so very often patients with amyloidosis will have pins and needles, numbness and tingling in their hands and in their feet. And that's a sign of a peripheral neuropathy. There are very few other diseases in the body or other organs that are affected that give you numbness and tingling. So numbness and tingling is really a very specific kind of symptom that the nerves aren't working right. Now, in terms of the weakness that people with amyloid develop, you get a trouble that starts typically in the feet, and where you have trouble moving your toes, and maybe the shape of your feet might change. So you get these hammer toes and high arches. As the muscles get a little smaller, they shrink. And then unfortunately, and one of the key features of amyloid neuropathy is that it gets worse. It gets worse over time without treatment. And we'll get to the treatment in a minute. But people with amyloid peripheral neuropathy, they get worse over time. So if you have numbness and tingling for 5 or 10 years and it doesn't really change, it's very unlikely that that's amyloidosis. So a lot of times people will have diabetes or other causes of, or common causes of a peripheral neuropathy. And then they wonder, well, could this be amyloid or not? And I say is that, diabetic neuropathy, for example, unless the diabetes is very, very bad and poorly treated, doesn't cause a lot of weakness. Whereas amyloid neuropathy, not only does it cause weakness in the toes, like I said, it also causes carpal tunnel syndrome. So people will have trouble moving their thumb up like I'm showing you here. They have pins and needles in their hands. The pins and needles wake them up from sleep at night. Those are typical symptoms of carpal tunnel. But diabetics also get carpal tunnel. So you have to see a neurologist who is versed in amyloidosis to be able to separate these things out from one another. The other feature of amyloid neuropathy is that people get weaker. So the weakness, and as I said, it starts out in the toes, but kind of specific to amyloidosis and very rare to occur in many other neuropathies, including diabetes, is weakness in the what we call proximal muscles, the muscles that are closest to the body. So the fingers are distal, the deltoid and the biceps and these muscles are proximal, and the thigh muscles are proximal. And proximal muscles are affected in amyloidosis very frequently. So people have not only trouble moving their hands and fingers, they have trouble moving their toes, but they also have trouble getting out of a chair, getting out of a car, getting off the toilet seat. So those are the hallmark features of a peripheral neuropathy from amyloidosis. It is difficult to make this diagnosis, and people are underdiagnosed for a long time. And as some of the emails that Muriel shared with me are the question of CIDP. And you know, about a quarter of patients with amyloidosis take a few years to get diagnosed. And so it's a very difficult diagnosis to make early on, because the neuropathy in amyloid looks a lot like the neuropathy of many more common disorders: diabetes, alcohol, drug-induced, and so forth. Now, CIDP in particular looks a lot like amyloid neuropathy to people who don't see a lot of these conditions.
Got to break in here. What is CIDP?
Sorry. So thank you, Muriel. So CIDP, which is a chronic inflammatory demyelinating polyneuropathy. So what is that? It's a mouthful is what it is. So it's chronic, meaning it goes on for a long time, years. So does amyloid. It's an inflammatory neuropathy. In other words, if you treat it with immunosuppressive drugs like IVIG or steroids or things like that, it tends to improve. Whereas amyloid is not really an inflammatory neuropathy, so it doesn't get better. And this is one of the features that distinguishes amyloid neuropathy from CIDP. And in that, people are very frequently diagnosed with CIDP because it's one of the few very treatable neuropathies, but so is amyloid now. But it is more familiar, CIDP is more familiar to neurologists than is amyloid neuropathy. And so very often patients will be treated with IVIG. And the rule of thumb is that if you have been diagnosed with CIDP and you've been given IVIG, or you've been given steroids, or you've been given some immunosuppressive drug, and you didn't really get a whole lot better after 3 or 4 months of treatment, have to reconsider the diagnosis. Sometimes it is CIDP and it's just refractory to therapy. And sometimes it is not CIDP and you have the wrong diagnosis and you've been barking up the wrong tree. So this is where it becomes very important to go to one of the big centers where they see a lot of second opinion work for neuropathies, and where people have, neurologists in particular, have particular expertise with either CIDP or amyloidosis or both, to be able to make the distinction. There are tests that should be done in almost all patients with a neuropathy that is progressive, and certainly one that's causing weakness, and that is an EMG test. So to make the diagnosis of amyloid neuropathy, we rely on the way a patient looks. So as Dr. Maurer says, the clinical phenotype, where they have weakness in the hands and in the feet, they have weakness in the muscles of the thighs and the muscles of the upper extremities. And then they have an EMG that does not look like CIDP. And it looks like a different kind of neuropathy, what we call an axonal neuropathy. And that's the most typical. Although, you know, everything you say in medicine and certainly in neurology, you have to sort of there's always an exception, and so you need to be aware of the exceptions as a provider of these diagnoses. And so once a diagnosis is established, and sometimes you need to do a nerve biopsy, sometimes you need to do a skin biopsy, sometimes you need to do even a heart biopsy, or some other tissue that you can biopsy and show that you not only have the genotype, where the either a blood sample or a saliva sample has been sent to a genetics laboratory to show that you've got a particular mutation or variant, as we call it. And then you have to show that you've got the disease in some tissue. And it doesn't have to be in the nerve to call it an amyloid neuropathy. It can be in the skin, and we make this diagnosis all the time. So once that diagnosis is established, what I typically do is share my patient with my cardiology colleagues. And the reason is when hereditary amyloid patients often have heart disease as well. So as a neurologist, I have no expertise whatsoever in heart disease. So I like to send them to a heart failure doctor who specializes in amyloidosis. And so Dr. Maurer and I have shared many patients in the past. Dr. Drachman at our place and many others are cardiologists who are really expert at diagnosing cardiac disease. Once we've established all of that, and then I get together with the other providers that are treating the patient. And this is a disease that really requires multiple physicians. It's not one doctor who can really treat the whole thing. And so we get together and we establish a plan for the patient. And whether, as we discussed earlier, whether it's a combination therapy of diflunisal and one of the silencers, or diflunisal alone or tafamidis alone, depending on what's going on. When a patient has a neuropathy, I'm very aggressive, or even, when a patient has a neuropathy, I'm very aggressive in treating them with a silencer. And the reason is the silencers are probably better they are definitely better than the stabilizers. So the stabilizers are diflunisal and tafamidis, as you've heard from Dr. Maurer. The silencers are the ones that reduce TTR. And so there have been many questions about TTR in the emails that were sent. And let me just spend a second about that. So Dr. Maurer described TTR as the amyloid protein that becomes amyloidogenic that misfolds. TTR, the other name for it used to be prealbumin. And so you can measure prealbumin in the blood. And the level of prealbumin is typically a normal level in most patients, not all patients with TTR, even untreated. But the idea is that you give a patient a silencer so that the liver stops making the prealbumin or the TTR, and then you can measure that the level is low. When you measure that the level is low, you know that the drug is turning the liver off from making the protein, from making the prealbumin or the TTR. So that's how you know that these medicines are working. And then you give the medicine to a patient with a neuropathy. And I like to give all of my patients, as much as possible, one of the silencers. Onpattro or Tegsedi, in the initial trials, the drugs are probably equivalent. They haven't been compared head to head, so I can't really tell you that one is better than the other. Both against placebo worked really well. I mean, stunningly well. So they both work very well. And it really, one is given by an IV infusion every 3 weeks. And the other one is given as an injection. And now there are currently ongoing clinical trials, as you've heard, both for heart failure as well as for neuropathy, where both of those drugs in slightly different forms are going to be given, but over longer periods of time. One is going to be every quarter, every 3 months, and the other one is going to be once a month. And so we'll see what these trials, they're being compared to the FDA, the currently FDA approved treatments. And we'll see the data, that data hasn't come out yet. Presumably when the data comes out, and we're all hoping that's going to be very positive as the initial data for the placebo-controlled trials, then the insurance companies should be able to switch you over from one drug to from the currently approved FDA drugs to the new drugs. There is one other thing that I want to mention is the Medicare coverage, just so that, because I know that this is a question that comes up all the time. Somebody said that they can only get the drug in an infusion suite and they can't get it at home. They're talking about Onpattro at this point. So medication is covered in different ways by different insurance companies, and Medicare is an insurance, essentially an insurance company, if you think about it that way, like many others. And there is Medicare Part B, as in boy, which is a benefit, your benefit plan. And that is approved to give you infusions in an infusion suite. So you can get Onpattro infused in an infusion suite. Medicare usually covers about 80% of the cost of the treatment. And then your secondary coverage like AARP or something else will pick up the 20%, and then you may be left with a copay at the end. To be able to get these drugs at home, you need to have Medicare Part D, as in dog. And that is the pharmacy benefit plan. And that will pay for Onpattro or whatever other infusions will cover some of that at home, but it doesn't cover some of the other costs. So there may be high out-of-pocket costs, and you have to figure that out with for your particular insurance. There have been some proposed bills in the various have Medicare pay for home infusions, but that hasn't gone through. So you may want to talk to your senator, your congressman about that, and lobby for that sort of thing. Because for some people, you know, who live far away from an infusion suite and have to drive a very long way, having a nurse come out to your house obviously would be a huge benefit. So I'm not going to say much more about insurance because I'm no expert at insurance. I just wanted to cover the highlights, and then you should really talk to other people who will be able, especially your insurance companies, who can fill you in on your particular needs. The last thing I want to address is sort of how do we know if the medicines are working or not? Well, we know that these medicines work based on the trials that we have. Unfortunately, they're not a cure, and it depends on where you are in your diagnosis. So the earlier you get treated, probably the better off you will be, because the more nerve damage you have, the less you will be able to recover from those permanently damaged nerves. The idea with these drugs is to reduce the burden of the bad protein, the amyloid protein. And so you want to get the treatment started as early as possible. Now, what is early as possible? And again, that's an individualized discussion with a patient. But you know, the general thought is the sooner you get treated, probably the better benefit you have. In terms of people who have had the liver transplantation and then have had, there was a question like that in one of the emails, liver transplantation and then got a silencer afterwards. There is definitely evidence that people who've had a liver transplant after a period of time, they will continue to progress, unfortunately. And probably the silencers will work for that. We don't really know quite yet, because it is a wild type that's being made, because, you know, after all, if you've had a liver transplant, they've taken out the liver that was making the amyloid protein and gave you one that doesn't make the amyloid protein. And yet you ask, well, why would you progress? Well, the reason you progress is because there's been actually some some studies that have shown, they've looked at the protein that was being made, and it's wild type protein. So wild type means it doesn't have the wrong amino acid in the sequence. And so the clinical trials that are going on now for wild type disease will show us if the silencers do work for wild type disease as well. So that's pretty much what I have to say. I think I'm about up to my time. And then I'd be happy to ask, to entertain any questions.
Wow, thank you. That was kind of everything you ever wanted to know about amyloidosis, but we're afraid to ask in 20 minutes or less. That was incredible. Thank you, Dr. Khella. I know we're going to have you back. Trust me. So with that said, you brought up a few interesting points, many interesting points, but actually one of them that you brought up was the home infusion question, which someone had sent in. But what I would like to do, because there are people who would like home infusions, but Medicare, the cost through Medicare would be too much. If those people would send me an email, if you would like home infusions and you're on Medicare, send me an email stating the state that in which you live and your type of hereditary amyloidosis, okay? And we will use that because we have been doing some lobbying to Congress with some other groups, and we will use the information that you give us to help us. We may ask you to contribute a little bit, but so don't hesitate to send an email to Muriel at amyloidosissupport.org, and you can put in the title line home infusions, and that would be just great. Thank you. Now, if we can have all of our doctors again, we're going to be answering some more questions. Dr. Khella, since you're our only nephrologist today, neurologist, we don't have a nephrologist, and we do have one question that reminds me, which I'm going to throw out to all of you, and that is someone who has wild type asked us to explain the connection between cardiac ATTR amyloidosis and the kidney, why their kidney is sick. So Dr. Khella, since you're on the screen, can you tell us why the kidney would be affected as well?
I think the kidney is pretty rarely affected in hereditary. I don't know about wild type, but in hereditary amyloidosis, it's pretty rare. It does happen, but it's pretty rare. But maybe the cardiologists who see wild type much more than I do can answer that question.
Okay, Dr. Punnoose, how about you first?
Yeah, I concur with Dr. Khella in that I think it's fairly rare to have renal involvement from the amyloid specifically. A lot of the times when we see renal failure or the kidneys being affected, it's because the output from the heart, which Dr. Maurer went over in his slides, is reduced when they have heart failure. And so our patients have kidney disease because they're not getting enough blood supply from the heart. So that's the way I think about it, as more of a pumping problem. And then they have kidney insufficiency as a result.
So a sick heart can make a sick kidney, so to speak.
And make a sick kidney because the kidneys are just not getting enough forward flow.
Okay, and Dr. Sarswat?
Yeah, I agree. I haven't seen too many people that I've said there's actual amyloid deposition in the kidneys from wild type TTR. I definitely see, what we call cardiorenal syndrome, where whether it's from lack of output from the heart or actually congestion of the kidneys, just because there's so much fluid buildup, and the kidneys tend to get angry and congested as well. I think it's more the challenging part for us is teasing that apart. Why are the kidneys getting worse? Because the volume, how much fluid, too wet, too dry, is always a little bit challenging in patients with amyloidosis. And I think the kidneys feel the back and forth there too.
And Dr. Maurer?
Yeah, I agree. There's not a real evidence of renal direct involvement by amyloid. I often try to explain the kidney involvement to patients in the following way. I don't know if this is useful. I'm a parent. I have 3 children, and they each need various amounts of attention at different times. And the heart is like the mother or father in the body. Its job is to supply blood or attention to all the vital organs. Turns out that people, I don't think, realize 25% of all your blood right now is going to your kidney to clean and produce urine and take care of the blood. And when the cardiac output is not high enough, it's analogous to the fact that you're not giving enough attention to the child. the kidney acts out. Kidney sends out signals. Those are called neurohormones that actually promote salt and water retention. That's why people are in a very salt avid state in amyloid heart disease. So if I eat some salt, thankfully I'll get rid of it. If someone with amyloid heart disease eats some salt, they'll hold on to it, in part because they want to stretch the leathery balloon. That is the heart that's thickened in order to fill it better. But the heart's already overfilled, kind of like children telling parents what to do. Most parents don't like that. And so I don't think the kidney should be telling the heart what to do, but that's what it eventually does. And so people do develop a renal insufficiency that's progressive. And unfortunately, that's one of the modicums of worsening disease. Everyone has shown that in staging systems, the worse your kidney function by your creatinine going up, or what we call your EGFR going down, is a marker of worsening disease, needing more diuretics and so forth. But there's no direct involvement per se by the kidney.
Okay, thank you. And then here we have patient written. My main issue began as neuropathy in the feet. I've been on patisiran for 18 months. And then he goes on having problems with clearing of his throat, coughs, some tightness in swallowing. And he had a swallow study done, which was normal. He's wondering if these symptoms could be related to progression of the amyloid or side effects to the patisiran. Then he also goes on to say he's now being sent to a pulmonary for PFTS. I don't know what that is. And he wants to throw more pills at him. Montelukast and Flonase. Well, will these even help his amyloid? Also, can you please explain about it being normal to have low vitamin A levels and prealbumin? Okay, and there's more, but that's a lot to take on right there. So Dr. Marson, well, we're going to start with neuropathy. So let's go to Dr. Khella and then we'll come back.
So the neuropathy doesn't really affect the swallowing in amyloid early on. So if you just have some numbness in the feet, that's really not, that may be something else. Now it could be amyloid itself in the what we call the oropharynx or the swallowing mechanisms, but that's something that needs to be evaluated by an ENT doctor. It's not a side effect of Onpattro as far as I know, but I could be wrong. Yeah, I don't think these are really related, right, based on what I'm hearing. But, you know, of course, it's very hard to give specific medical advice to a particular patient. So you really have to go back and talk to your doctors about this.
Right. Some of our questions are kind of second opinion questions, and we get that for sure. But some of them are of general interest. Okay. Anyone else want to add to that? Okay. How much? Go ahead.
I was just going to note that I think the concern or complaint, if I heard it correctly, was that there's a lot of like runny nose and rhinorrhea, what we call upper congestion. I observed that in a lot of patients. They all complain about that. I have to be honest and say I'm not sure that I know why. I do have a theory. I'm curious if my colleagues might agree, and that is, you know, when the heart doesn't fill right or pump well, all the veins back up. So when you're getting examined by a cardiologist, they're always looking at your neck vein, and the venous pressure is very high. And if your venous pressure is very high and all the venules in your face, I have a feeling you're going to produce by oncotic pressure a lot of a runny nose. But patients do note that they have a kind of you know, mucus in the back of their throat often. They have a runny nose very, very, very frequently, and it's quite bothersome. I don't particularly find that any of these therapies, the Flonase and or the allergic medicines, are quite helpful. But
okay, colleagues, Dr. Punnoose, Dr. Sarswat, thoughts on that? Thoughts on the theory?
I hear other patients saying the same, the similar kind of complaints that Matt, you're talking about. I can't say I've ever been able to rationalize or quite the way you did, but I guess that makes sense. I'd love to have that discussion with an ENT doctor, but I do have patients that have similar complaints, definitely.
Yeah,
runny nose is a very common thing, you know, so.
I will say I'd never considered the thought about kind of venous congestion and oncotic pressures. It's very interesting. I do agree. A lot of my patients have similar symptoms. Not sure how to put them together.
We hear a lot of people talking about a non-productive cough as well. But
Muriel, can I ask Dr. Khella a question? That
we will let you ask him anything you want.
So Sami, many patients with variant disease that we see early on who are, relatives of someone who's affected, obviously will have, as you mentioned, carpal tunnel syndrome or even lumbar spinal stenosis and radiculopathy, what I describe as a compressive neuropathy. And they often ask me, well, so I have amyloid there. You've actually biopsied my carpal tunnel and showed it. So why can't I get treatment? I have a hard time describing, to them that carpal tunnel or lumbar spinal stenosis without a peripheral neuropathy that is in the nerve, as the way I think about it, is an indication for treatment, or maybe I'm not treating the right people. So I'm just curious what you say to individuals like that who are appropriately concerned because they have evidence per se of amyloid somewhere, but it doesn't seem to meet at least our current way to get them access to treatment.
Yeah, so I find if I find evidence of amyloid in the carpal tunnel in somebody in their late 30s, or I will treat them. And because they've had, especially depends on the variant. And if they've had a variant that manifests in the late 50s and they're in their 40s, it's like, why wait? So my feeling is, and I think this is the feeling of other amyloid neurologists as well, is that if you find it, treat it.
And Sami, is that treatment with an siRNA, or are you talking
about with a silencer? Yeah,
with silencer.
Okay.
Dr.
We try to find any excuse to treat early because especially because the neuropathy trials have shown such an amazing benefit, really. And so this is probably the best time to treat these patients early on.
Everybody's running to the University of Pennsylvania right now to see you, so just so you know. Okay, Dr. Maurer, I have to ask you, what is radiculopathy? Or am I pronouncing that wrong?
I'll defer to Dr. Khella, but my understanding it's, pain and sensory and disturbances related to where the nerves run, in part because of, compression, for example, by the spinal cord of the nerves from amyloid.
And Dr. Maurer, from your perspective, do you run into difficulties getting patisiran, for example, approved for such patients?
I'd have to ask Dr. Brannigan. He's more engaged, obviously, in patients with neuropathic phenotypes. But I think there's a discourse out there about whether carpal tunnel syndrome itself is evidence enough. It's some have, I think, submitted. I don't know if they're right or wrong, that this is a compressive neuropathy, not a peripheral neuropathy, and that I don't know. I've heard people say those subjects were not included in, for example, the randomized trials. And so, there are insurances, I guess, that could deny coverage.
Okay, thank you. And the last but not least on this, and it's a question people often have, is how much vitamin A to take. And if this drug blocks thyroid hormone, should TSH also be monitored, and does it need to be treated? So Dr. Maurer, you're on the screen, so how about taking that?
Yeah, well, so all these drugs are going to lower transthyretin. Transthyretin, also called prealbumin, stands for transporter, thyroid hormone, and retinol. So it's the only transporter of vitamin A. And so you definitely need to take, with a silencer, vitamin A supplements. The recommended daily allowance is like 3,000 units per day. And it comes in various formulations, some of which are a little bit higher than that. And because it's a fat-soluble vitamin, I'd be careful about taking sometimes too much. It turns out that TTR is a pretty minimal carrier of thyroid hormone. There are many other proteins that do it. And amazingly, silencing TTR or using tafamidis or other stabilizers does not have significant effects, in my experience, on thyroid hormone.
Panel, do you agree? I see nodding.
And it also doesn't have much of an effect. I don't know, Matt, if you've seen, or any of the others have seen, change in vision, but I have not really seen any effect of vision, because it does carry retinol, which is used in vision.
We haven't seen any effect, but that's why we recommend actually to take vitamin A to prevent night blindness. And when you take it, there hasn't been, in my experience, any significant effects on visual acuity. And we encourage patients to see an eye doctor on a yearly basis. And there are many of the studies that were done, targeted eye exams and/or questionnaires.
Okay, thank you. Okay, here's a good question. Okay, what is the status of the treatment for wild type ATTR with doxycycline and ursodol? We haven't heard about that in a while. So, Dr. Maurer, what are your thoughts on doxycycline and ursodol? I think we recently saw a study that said doxy was not necessarily what people had thought it was going to be. So, what are your thoughts?
Yeah, I would say that that's a good summary of what's happened with doxy. I haven't prescribed doxy in a long time. The evidence was basically mainly in the test tube. There's a randomized trial, not in TTR and AL, that didn't show any clinical benefit. And the evidence probably was maybe even stronger in AL than TTR. I think with the emergence of a proven disease modifying therapies, both doxy and TUDCA have kind of appropriately fallen off the therapeutic armamentarium, and I don't prescribe them.
What about let's throw in green tea extract too, ECG, GC, as long as we were at it. What are your thoughts on that?
Similar.
Similar?
Yeah.
Okay, we'll go to the panel now and see if they agree. Dr. Khella?
I'm sorry?
What are your thoughts on green tea extract, doxycycline, ursodol, TUDCA?
Yeah, well, for neuropathy, no, not much.
Okay, great. And Dr. Sarswat, what are your thoughts?
I mean, in terms of the doxycycline and TUDCA, I would say I generally mention it to most patients, but I definitely don't have it as first line. I think if we're, from a financial perspective, if we're stuck and we can't give them anything, there are times that we'll still talk about it just to be able to offer something. But it's, I mean, I always share that the data is just so minimal.
And Dr. Punnoose?
I haven't really used it myself in TTR. I have a few AL patients who are on it, but and that's doxy, and definitely have not done anything with green tea extract.
Okay, so for all intents and purposes, we can say that those are X treatments that were around when we needed some hope because there was nothing else available. But now that we have real stuff available, that's kind of null and void. Would that be a good summation there?
Yeah, I would favor taking them off your chart.
Okay, it's leaving the chart. Well, let's take a vote. Should that leave our chart? Dr. Khella? Dr. Punnoose, should that leave the chart? Yes. And Dr. Sarswat, you're not sure about it leaving the chart, I think, right?
I think I'd be comfortable with it leaving the chart.
Okay.
We have much more to offer now.
I know we on our AL chart, we have one treatment that Dr. Suzanne Lynch at Columbia wanted off the chart. And one of our other doctors at another meeting said, leave it on the chart. So we left it on the chart. But now next time I have a meeting with Dr. Lynch, I think I'll take it off the chart just for her. So there you go. Okay, here's one. Onpattro lowers your level of prealbumin. Does well, Dr. Khella mentioned this before a little bit. Does low prealbumin levels cause muscle weakness, stiffness, and cramps in the leg? Dr. Khella?
No, it's not. It's not the low prealbumin. Muscle stiffness and cramps are common. You know, as you get older, they're just common part of life. The neuropathy, people with a neuropathy very often will have a cramp, just get cramps as part of the neuropathy. So that's not an uncommon thing, but it has nothing to do with either the medicine or the specific disease. It's a very non-specific thing. And even normal people will get cramps all the time. So, you know, cramps are often seen in people who are either dehydrated, have used those muscles extensively, or the feet or the hands are very cold. Those are common things that cause cramps. There are no real good medicines for cramps. You know, I just tell people to stay well hydrated and keep your limbs warm. Use socks at night if your feet are cramping up.
No pickle juice?
I was gonna say pickle juice. So football players keep pickle juice on the side of the field. I don't know. I tell people, if you like pickle juice, drink pickle juice if it's not so bad for your heart. But I don't want to get in trouble with the cardiologist here.
Oh, because of the sodium in there.
Oh, because of the salt.
Okay, well, 1 or 2 pickles a night then maybe, huh? Okay, here's another prealbumin question here. And maybe we'll make it the last one because we've kind of overdone it. Is anyone aware of any studies that determined at what prealbumin levels is a typical person with hereditary TTR? Is there any data on average transthyretin levels in individuals who are being treated with the infusion form of patisiran? Are there any other tests that can measure the level of a hereditary TTR in a person's body? And then there's a cardiology question here too. Is the pro-BNP test a good indicator of a person's heart status for individuals with heart-involved amyloidosis? Are there any other better tests? And here's two more that go with that. Why would a test laboratory report a transthyretin level as greater than 1.7 milligrams per deciliter instead of providing an exact number? Okay, they don't like the greater than part. They want something more definitive. And how low of a value can test equipment measure transthyretin? So that was a lot of stuff. I don't know if you remember any of it, but let's go back to the prealbumin question and the transthyretin level for Dr. Khella. Is anyone aware of the studies that have determined at what prealbumin levels in a typical person, what they should be? Or
well, so there's a range, and depending on the kind of test that the laboratory that you went to has measured the prealbumin level. So the numbers and the ranges are variable. But what we do know is that when you take the silencers, like either Onpattro or Tegsedi, you will drop the prealbumin level by about 80% or so. So, you know, it should go down. Now, many people don't measure prealbumin levels, you know, before you go on a silencer and afterwards. But that's the basic idea. The basic idea is that these drugs really lower the level to a great extent, which is how we think that's the way we think stops or slows the disease down.
okay, are there any other tests that can measure the level of hereditary amyloid in a person's body?
Well, you can biopsy a tissue, like we said, and you don't measure a level, but you measure its presence. But we don't measure levels of amyloid burden, if you will. Maybe the cardiologists have a way.
Well, okay, well, back to the cardiology question now. Dr. Maurer, we'll start with you. Is the pro-BNP test a good indicator of a person's heart status? Are there any other better tests that can be performed?
Yes, a NT-proBNP is a very good biomarker of what's going on with the heart. And it's something that most cardiologists taking care of patients with amyloid will follow. You know, we've established staging systems that allow you to kind of rate. And one of the variables in the staging system is the NT-proBNP. It was actually the one that was used by both the National Amyloid Center and the Mayo Clinic synonymously, and the value was above or below 3,000 picograms per ml. So yeah, that's something I think that's quite useful to follow. With regard to, I think, the broader question of how to follow amyloid, this is a common question. Dr. Khella mentioned before, how do we know the drugs are working? We use the biomarkers, we talk to patients, we evaluate their functional capacity. But I think there's probably a need for better testing. The things that are emerging, I would say, are more sophisticated cardiac tests, such as MRIs and or PET scans. And in particular, PET scans using certain isotopes can actually identify amyloid in probably any organ in the body, and might be useful to actually track or follow things over time. So we'll hear a little bit later from Spencer about Atralis, but those kind of programs are pretty intriguing, and I think can identify the load of disease and how much amyloid you have, and hopefully see it regress over time with treatment.
Okay, great. Any other additions to this before we go to the next question?
I think the only thing I would add, you know, I similarly follow biomarkers, troponin and BNP in all of our amyloid patients. I'm a strong believer in the power of cardiac MRI and helping us understand the amount of amyloid involvement there is in the myocardium, and following certain parameters like T1 time and ACV. And I will, you know, serially try to get those on therapy and try to understand what is happening to those parameters as patients are on therapy. And I think that's going to be useful. I think we're going to prove that to be useful in the future.
Okay. Well, I'm behind as usual, folks. Okay, anyone that's ever taken part in one of our webinars knows we rarely, if ever, have ever followed an agenda. But with that said, a break is super important right now for many reasons. So we will take a break until 2 o'clock Eastern, which would be 1 o'clock Central. And thank you very much. Okay, now we're going to hear from Paula Schmitt. And Paula is going to tell us some information about financial assistance. So we already heard from our physicians and how expensive some of these treatments are, and there is help available from the very pharma companies that produce these drugs and also from other places. So Paula, take it away.
Thank you, Muriel. Yes, I want to also talk to you very briefly about genetic testing. That's something we haven't touched on. Bob can get my slides up there. I will show you the different sites that you can go to. Next slide, please. Okay, these are the two available companies for getting free genetic testing and genetic counseling done through. If we have people that are in Canada, the counseling may or may not be available to you. I can't remember right at the moment, but it is a little bit different in Canada as far as what these two companies will cover. But if you have someone that needs to be tested, you can contact either one of these companies. I have already put it in the chat, the addresses, so you can copy them from chat. Next slide, please. I am very happy to be able to announce some good information today, some good news. There's money available. Healthwell Foundation announced earlier this week that their fund is now reopened for re-enrollment patients only at this time. If you have had a grant with the Healthwell Foundation in the last 3 years, you are eligible to file re-enrollment application papers right now. Do not know how long this will last, so you need to act on it quickly. I am hopeful that possibly in the next few weeks that they will open this to all patients, including new patients that have not gotten a grant before through the Healthwell Foundation, but I am not sure. I'm basing that on past years and what they have done then. So I'm hopeful that it will open, but like I said, I don't know for sure. Patient Access Network and the Assistance Fund are two other funds that offer financial assistance to patients with TTR amyloid. They are both closed at the moment, though, but they have waiting lists that you can sign up for. So I urge you to do that, because when you have done that, they will send out a notice to you to let you know, excuse me, to let you know that the fund has reopened. Next page, please. Okay, the financial assistance is based on your income, and that varies with each one of these different companies. Healthwell, excuse me, Healthwell Foundation is 500%. So if you look in the blue column, say if you're a family of two, you can make $91,550 a year and still qualify for their assistance. So you can take a look at this chart and tell if you fall within those limits or not. I can make this available to you. If you need to know the amount, you can email me at paula@amyloidosissupport.org, and I will send you a copy of this chart to make it easier on you. Next slide, please. The Fund Finder program is something that everyone should download. It is done through the Penn Foundation. It is an app. They call it an app, but it's not an app in the way that we know of an app for our phones nowadays. I'm going to try to call it a program more than an app. But if you go to their website, download this Fund Finder program, you tell it that you are an amyloid patient, you want to know about funds for amyloidosis. On the screen, you will see several different foundations listed. This is an old slide, so I just wanted to show you because this old slide had Leukemia and Lymphoma Society as an open fund at that time for patients with AL. But if there is a fund open, you will see a green padlock out to the left like you do on that one line. If you see a red padlock, that fund is closed at that time. But this program will also email you a notification when these funds open back up so you can jump on them quickly. I highly recommend that you download these programs and get on the wait lists for each program if they offer one. It's a sure way to know that you're going to get notified when it reopens. And since some of these funds can only be open for a day or two when they do reopen, you want to be able to jump on it as early as possible. So just keep that in mind. Next slide, please. Now, for those of you that may not be able to afford your drug at all, whether you're on Medicare or not, you can contact the pharmaceutical companies. They may have means of assisting you. Some people do qualify for free drugs through the foundation sides that the pharmaceutical companies have. If you're not on Medicare yet, you may qualify for a copay assistance card that helps cover your copay. So always be sure to contact them. These addresses are also placed in the chat where you can access them yourselves. But, just know that there is assistance out there. Sometimes you have to fight for it. You got to be waiting for those chances to jump on it when the funds do open. But these you can contact at any time. Just know that they're out there. So that's basically it for right now, but at least there is a little bit of good news out there for those of you that have had those grants in the past, and I urge you to apply today after this is over. Go ahead and fill out that application online if you can. All right, I'm going to turn it back over to Muriel.
Thanks so much, Paula. We get more feedback on your presentation, positive feedback. People love it. Thank you so much for educating.
Who doesn't like money?
Right? Exactly. Okay. Here's someone who has a question on carpal tunnel. They want to know, after several years, they were advised to have surgery on their carpal tunnel, and they want to know if such is the normal surgery. Is it recommended that there's any additional risk if they have amyloidosis and they have carpal tunnel surgery? So I'll hit Dr. Khella first and ask, what about carpal tunnel surgery? Will it come back? What's going on?
So carpal tunnel is where you have numbness and tingling in these first three fingers of your hand. Yeah, very often people will get the numbness and tingling at night. You shake your hand. Sometimes it's bad enough that it wakes you up from sleep at night. When it gets really bad in people who have amyloidosis, the muscle on the palm of your hand, that's the muscle right below your thumb, will shrink down and get very small. Depending on how much nerve damage you have, how much neuropathy you have, because also the nerves, as Dr. Maurer was talking about, the nerves in the hands can become affected from amyloid, as well as the carpal tunnel, which is really a nerve problem where the nerve is getting pinched, very much like when you are cross your legs, for example, and you pinch the nerve in your leg and your foot falls asleep. So that was what we call a compressive neuropathy, which is different than amyloid neuropathy, where the nerves themselves are getting damaged. So the nerve can get damaged from being pinched, compressive, or having amyloid deposit in the nerve itself. Now, if you don't have amyloid in the nerve itself, if you don't have the amyloid neuropathy and you only have the compression of the nerve, the operation should be pretty successful, depending on how advanced the compression is. You know, sometimes you can have a really bad carpal tunnel if you've ignored it for years and years and years. It becomes a little trickier when you have a neuropathy, and you sort of have to weigh the pros and cons of having surgery when you have both the carpal tunnel and you have a peripheral neuropathy, because then depending on how advanced the neuropathy is, your numbness and tingling may not get better. So it really, again, is individualized. You very often need an EMG to sort it out, to see how much neuropathy there is, how much carpal tunnel there is. And so you really, it has to be an individualized decision as to how to proceed.
Super, thank you so much. And I'm sure, Michael Maitland, you don't mind that I kind of stole a minute from you to get that question answered. Thanks so much. Now we're going to hear from Intellia. We hear the term CRISPR all the time, right? And so we're going to hear from Michael Maitland from Intellia. So Michael, are you ready?
I think I am. Give me a chance here to share my screen.
Thank you for coming, by the way.
Oh, it's my pleasure. Thanks so much for having me specifically. And of course, more generally for Intellia to have the opportunity to have some time along with all the other great scientific groups that are working to make this disease a little bit easier to live with. Okay. That should give you the screen. I haven't participated in this forum previously. I started listening in occasionally about a year ago when I first joined Intellia. For 20 years before that, I've been a physician scientist practicing in medical oncology. For my career, I took care of many cancer patients almost exclusively on clinical trials. Oftentimes those were phase 1 trials. I simultaneously ran a research program that mixed genetics, clinical pharmacology, and patient-oriented research to try to understand how to better personalize treatment, how to run clinical trials with an eye towards ultimately having more personalized way of treating instead of having one dose for everyone. One of the great things about coming to Intellia as a physician and being one of the first physicians to work for Intellia is that there was this terrific spirit among the scientists in the company of wanting to understand disease and really learn more about individual patients' personal experiences. I think as a way not only to motivate the laboratory team and all of the great support staff that work for our company, but also to have that sensitivity and awareness of the importance of the work that the company is engaged in. The company was co-founded by multiple scientists, but no doubt the most famous is Jennifer Doudna, who became famous not just for the original discovery of using CRISPR-Cas9 in mammalian cells, but also she received the Nobel Prize in chemistry with some other notable scientists back in 2020. Without getting too deep into the technical details, Intellia is committed to developing new therapies that we hope will be more effective and notable for perhaps only needing to be used once in a patient's lifetime in order to directly modify genes that are causing in some way a particular disease. And so many of you here know ATTR amyloidosis, certainly personally, but also scientifically quite well, and therefore may see immediately the value of the capacity to deliver medication to the body that will make precise edits directly in the DNA. In the case of ATTR amyloidosis, whether you have the heritable form or the wild type form, we think that there is an advantage to inactivating the gene regardless of whether you have a mutation there or not, with the concept that by introducing the medication into the liver where the TTR protein is synthesized and getting at the source of that protein making machinery, the DNA, you knock out the TTR gene. Downstream processes that are part of the normal biology are that the gene encodes for the messenger RNA that is made in the nucleus. The messenger RNA gets out of the nucleus and into the cytoplasm. In the cytoplasm and in other structures in the cell, the messenger RNA can be converted into transthyretin or TTR protein, which is then secreted by the liver cells into the bloodstream and circulates all over the body. When you have the TTR mutations that cause ATTR amyloidosis, these proteins are relatively unstable and consequently will have a tendency to form amyloid fibrils and ultimately cause harm to nerves, heart tissue, and other organs in the body. So the current therapeutic strategies, for example, tafamidis, are intended to keep this protein more intact and less likely to form the amyloid fibrils. Inotersen and patisiran, which we refer to generally as RNA silencers, will keep this TTR messenger RNA from forming the TTR protein. And NTLA-2001 featured here is this one-time delivery of these clusters of fat that we call lipid nanoparticles. That's the circular structure that you see here. And they will deliver messenger RNA, the squiggle here. Notably, the structure of this compound is reminiscent of the COVID vaccine that many folks may have received, either the one made by Moderna or the one produced by Pfizer, where you have a lipid nanoparticle and messenger RNA inside. And the idea is to deliver this one time intravenously. It will find its way to the liver. The lipid nanoparticles will release their contents, which will then find their way into the nucleus. And the TTR gene through this process will be knocked out so that it never again produces TTR mRNA, and therefore the entire process is effectively shut down. Now that's our hypothesis. We have exciting data in animals to suggest that it works. And then many folks are aware, skip ahead for a moment, that we did have the honor of publishing on the initial group of patients participating in our phase 1 trial to establish the concept that when folks received a single dose of NTLA-2001, we did indeed measure much lower levels of transthyretin in their blood as soon as 28 days after receiving the treatment. And the idea behind this is if we can change or possibly even completely shut down the protein production, then the expected result is a reduction, certainly in progression of the disease symptoms. And perhaps we hope if we can knock down enough of the protein that we might even see ultimately improvement in disease symptoms. So we're currently running a global phase 1 study. The study that was described in that New England Journal of Medicine paper has now expanded. So we are currently running the clinical trial in polyneuropathy, which has moved from its dose finding phase into now the first part 2 testing of the same dose in a group of patients and monitoring them over time to see if their neuropathy improves. And then we more recently have opened a cardiomyopathy cohort where we are testing to see if the dose that looked to be active in the polyneuropathy patients would indeed be the same dose for folks who have cardiomyopathy. And so ultimately we expect to enroll up to 74 patients. I know I'm speaking largely to a US-based audience here, and we are not yet opened with the study in the United States. The patients right now are participating are either in New Zealand, Sweden, or the United Kingdom. But again, I want to emphasize the idea is to administer a single IV infusion once in order to achieve all of these intended downstream effects. Another striking thing for me as a physician scientist who had earlier in my career spent a lot of time learning the hard science of population genetics, I was really impressed with the thoroughness with which our laboratory-based teams that are developing these compounds in the first place actually explore the right sequences for the RNA that goes into the drug to make sure that when we are targeting the TTR gene, we're targeting a region that is shared across the entire population. That this is not a region where people of one ancestral background will have a mutation and others won't, but one region that should work truly for the whole human race. And of course, one of the exciting things, and I think one of the reasons we've had this early visibility of success, is all the folks who've been working in this field beforehand. Obviously, the agents that many of you are taking that were developed by Alnylam and Ionis, they were the proof of concept that established that Intellia should aim to develop gene editing therapy first for patients with ATTR amyloidosis. So that's a sign I should end the show. Thank you for your time and attention. I look forward to participating in the discussion.
Thank you, Dr. Maitland. And that discussion will take place after all of our presenters. But I have a quickie question for you.
Please.
Is one of the reasons that you're only conducting the trial in the UK and New Zealand, and I forget where else, Sweden, I think, because they don't have as many patients on Patro or Texeti or tafamidis, so you're able to get treatment-naive patients that have had no treatment whatsoever?
Thanks for making that point, Muriel. Absolutely. When you're in these earliest stages of testing any medication, because there's so much unknown, you typically want to focus on only enrolling patients who are at a point with their disease or are only able to receive care in a health system where these other good treatments are not available to them.
Okay, thank you so much. Next, we have from Ionis, Gustavo Buchel. Take it away.
Good morning, good afternoon, you all. Let me open my slides here. Okay, I hope you can see it. Good. So thanks for having me here again. Always a pleasure to be in these meetings with Muriel and all of our colleagues here. So my name is Gustavo. I'm going to talk a little bit briefly about the Ionis compound and the clinical trials. We've been discussing this in these meetings before. So as you know, the name of our compound, it's eplontersen. You probably heard this before as Ion 682-884. That's the official name in the documents, but also you heard TTR LICA or maybe Axia TTR LICA, but finally we have the proper name. I hope it's a catchy one, eplontersen, and we're going to be referring to the drug as eplontersen from now on. As you know, eplontersen is a drug that goes in the bucket of the silencer, together with the drugs that Alnylam are bringing. It's a compound that blocks the RNA messenger in the production of the protein, and it can be done with a good success in the liver, especially with the new technologies for a better targeting and delivering of the drug, the GalNAc technology that the most recent drugs are using, that makes the doses and the potential side effects much less frequent, and probably with a very clean safety profile. So let me tell you a little bit about our development. So the first study that we start working when we have this compound ready to go for clinical research is in the polyneuropathy phenotype. The study is called NeuroTransform, and the study was fully enrolled already a few months ago. It was fully enrolled. There is a very interesting design when we have patients using the drug, eplontersen, but also patients using the parent compound, the current silencer approved for the treatment, inotersen. And the historical control, it's from the registrational study, NeuroTTR, from inotersen in the past. So here you see that the patients will move from inotersen to eplontersen after around 35 weeks here. And then we have final analysis around 15 months and 18 months. So as Colleen properly said before, the very nice results from Helios-A, the interim analysis that were presented recently, this is happening for us now this year. So we have a similar program, I would say maybe 6 to 9 months chronologically behind. And so this year we hope to have some interim analysis of this trial, bringing also good results, promising results for the future of the molecule. And again, one more option, one more therapeutic option for the patients. The study also that I would like to bring to you that are still recruiting, so it's a little bit different situation here, is the Cardio-Transform study. So it's the same medication, eplontersen, the same dose, 45 milligrams subcutaneously for both phenotypes. And here we are looking for patients with the cardiomyopathy phenotype, both wild type or hereditary. And these patients come to a trial that will take in average 2.5 years, and then an open label extension. This study is still enrolling patients, but fortunately, I would say we are getting closer to the numbers we need to accrue in this project. So we are closing some sites in the United States, and we are keeping still some sites open in Europe. Dr. Maurer, that's here in the panel today, it's one of the sites that are still open in the United States. So here the patients come to the trial and receive placebo or the treatment. However, drugs that are currently approved, like the tafamidis, are fully allowed in this trial. So the patients are not requested to not take one of the drugs that's proving to improve mortality and well tolerate, like the tafamidis, in this trial. So I think this is something very interesting and helpful, and will shed a lot of light on the understanding of silencers and stabilizers together in large trials or in the future therapeutic options for combinations. So finally here, I show you just a few contact points for the Cardio-Transform trial. If you're still interested in potentially participate or know people that you can refer for the sites that are still open in the United States and Canada, and we still have a good footprint in Europe. And of course, we are open for more discussions and questions later. Thank you very much.
Thank you so much, Gustavo. And I do have a question for you right away that kind of got triggered. And that is, you said that the trial is open in the United States in some locations for those with either hereditary or wild type cardiac amyloidosis, and that they can stay there. There isn't a true placebo group in the sense that if you're on tafamidis, you can stay on tafamidis while you're on it. But what about if you're on diflunisal?
That's a very nice question, Muriel. We would love to be able to compare the drugs to all the other options in the market, but to have a clean clinical trial, as pointed out before by our panelists, you have to have a proper objective. So diflunisal, as pointed out by Dr. Maurer, it's a drug that can be one of the options for these patients. However, in a clinical trial like this, considering the Cardio-Transform patients are patients that had generally the median age in this trial around the 75 years old, then diflunisal, maybe it's a drug that's been an anti-inflammatory, could have some renal bad effects, and could maybe bring noise to the results of the trial. We prefer to go for the drugs that are approved and have mortality benefits, like the tafamidis, which we would consider a malpractice not to prescribe to patients in this country. So we focus on the approved mortality data drugs, and that's why we are asking not to have diflunisal being in this trial. So diflunisal will need a washout of 14 days. You can be on diflunisal, but you have to stop to start the trial, not tafamidis.
What percentage of the people would be on the placebo and part of the trial?
So this trial is a randomization 1-to-1. So for every placebo, we'll have one patient on treatment. We are currently with the plans with having around 7 to 800 patients in the trial. So half on placebo and half on treatment.
Okay, Dr. Maurer, if you're there, I wanted to ask you how you felt about putting wild type patients on the placebo arm of a trial when they might not be, when they're not on tafamidis and they might be on nothing.
Yeah, I don't think that's a good strategy. We have a proven effective therapy that works for patients, and that's why I endorse the approach that Gustavo and his team has taken. In our practice, we now know tafamidis is associated, as we said, with significant mortality benefit across the spectrum of disease. And so we favor starting proved therapies, and then patients can be randomized. I think patients are appreciative of this approach, to your excellent point, Muriel, knowing that they're not, God forbid, getting nothing anymore. Back in the days where we had no proven treatments, then it was seemingly reasonable, I think, to randomize people to placebo, but that's, I think, not the standard of care anymore.
So this trial would be more popular in countries like we were talking about Intellia, where there's no treatments available or readily available. Correct?
Correct.
Okay, thank you. And now last but certainly not least is a face that is very familiar to all of us, and that is from Atralis, Spencer Guthrie. So Spencer, are you there?
I am here. How are you?
I'm
Can you see
fine,
my
thank
screen?
you.
So thank you, Muriel, for allowing me and inviting me to join, and Paula and the others from ASG, as well as it's good to see a lot of familiar faces and colleagues, and always a pleasure to be able to present to patients. So just a little bit about Atralis. So Atralis is a newer company. It was founded by Jonathan Wall from University of Tennessee and me. And we're really wholly focused on amyloid diseases, so improving the lives of amyloidosis patients. We work on both a diagnostic and also on therapeutics that are focused on removing amyloid. So just, you guys all know this, some of the mechanism was explained, but I just want to point out one thing is, so the way that amyloid fibrils are developed between TTR and AL and other types is different. So there's different involvements of different organs, different precursor proteins, but the end result of these diseases are these insoluble amyloid fibrils that get deposited in patients' organs. And there are a lot of commonalities in those fibrils across these diseases. So what we're focused on is targeting the fibrils and the commonalities in the fibrils. So both the diagnostic and therapeutics we're working on are targeted to something on the outside of the fibrils, and theoretically, what we're calling pan-amyloid, they will be able to diagnose and treat patients with any type of amyloid disease. So that's obviously a potential, but that's our goal. And we have a pipeline of 3 therapeutics and a diagnostic. I'm mostly going to focus on the diagnostic today because that's where we're enrolling patients. But we do have 3 therapeutics. They're, again, entirely focused on the removing amyloid through engaging the immune system. There are 2 that are using the same peptide technology as the diagnostic. And sorry, my dog is barking here. And then another therapeutic that's using SAP, which is serum amyloid P targeting technology. So using the same protein that's used in the SAP scans in the UK to target the amyloid. So our imaging agent is called AT01, now has a kind of an official name of iodine evuzametide, and this is a peptide that's been radio labeled with iodine. So what we see as the advantages here are really improving patient diagnosis. So some advantages of the product, potential advantages, it's an uninvasive product. It does recognize different amyloid fibrils, so potential to diagnose AL, TTR, and other types. We are able to detect amyloid in multiple organs and really quantify how much amyloid is there. And so there's been a real inability in the field to see exactly where the amyloid is and see how much is there. Previously, there's been a lot of work done, particularly in cardiac imaging, that can help with that. But a lot less in multi-organ disease. We want to use this for therapeutic development as well, because there's not been a really great measure to look at amyloid removal over time. There are certainly surrogate measures for that, but we think it's important to have a direct measure. And most importantly for the patients, I'm sure many of you had a difficult diagnostic journey that took a significant amount of time with a lot of tests, and that's our goal here, is to facilitate diagnosis earlier and to improve the accuracy. So Jonathan Wall invented this agent, and he's part of Atralis now, and this is now agents owned by Atralis, but he did conduct a phase 1/2 study that had 50 amyloid patients. 20 of those were TTR. 11 of those had been previously diagnosed with cardiac disease, and we were able to see cardiac uptake in all 11 of those. Additionally, we did see amyloid in a number of other organs, NAL and TTR. And there was a question earlier about kidney disease. We did see kidney deposits in, I think it was approximately 30% of patients with TTR. So it's not always, some of these are subclinical. So you can see deposits that are not causing, at this time, a clinical issue. But all of these diseases really have, they're really impacting multiple systems. And then we also look at 5 healthy volunteers as control to see what the normal distribution is. And there were some mild and transient AEs associated with the tracer. Just to show you a few images, these are some TTR patients that were diagnosed with cardiomyopathy who came into the study. And you can see this uptake. This represents uptake in the heart, and you can see the whole. This is almost the left ventricle is certainly heavily influenced or heavily amyloid laden, but you can see right ventricle in some of these patients and atria in others. But you see really good clear uptake in the left ventricle of the heart in all 3 of these patients. Just to mention, there is also what we call iodine or radioactive spillover, where the radiotracer gets processed through the body. So in the stomach, bladder, and sometimes in the thyroid. And this is background. So this is not amyloid. This is, we look at healthy volunteers, and this is there in healthies as well. So in these 3 patients in particular, you can see the heart. So we had some other really interesting findings. There were a number of hereditary polyneuropathy patients who came into the study and had not been diagnosed with cardiac disease. And we were able to visualize cardiac deposits in these patients. And so, this is early, and I think there are approximately 4 or 5 of these patients. But our hypothesis is this is subclinical cardiac disease, and that in the future these patients may develop cardiac symptomology as well. So again, these are two examples. Both these patients had completely normal NT-proBNP, not elevated, no cardiac symptoms, and they had negative pyrophosphate scans. So I think it's relatively well known that pyrophosphate scans don't bind directly to amyloid, and may miss patients who are earlier in their diagnosis. And so, we hope that this proves to be a more sensitive scan of picking up disease early. And just to show kind of some of the multi-system disease, we're also able to pick up, as I mentioned, multiple types of multiple amyloid in multiple organs. But I think, as you all know, the amyloids, often impacts both carpal tunnel, spinal stenosis, and sometimes in the joints. So we were able to see in this patient, this is amyloid uptake in the shoulder. We can see it in the hand in this patient, and this patient did come in with carpal tunnel, complaining of hand pain. And then you can see deposits as well in the spine of this patient, and this patient has spinal stenosis. So what's going on now? So we have an ongoing study we call a test-retest study, and I'll explain in a minute, and it's enrolling AL and TTR patients. We're planning a phase 3 study. There will be an international study enrolling about 200 patients, and we'll be beginning at the end of this year. And then there are other investigator-initiated trials that are being planned. This test-retest study includes 2 imaging tests over a 6-week period. So it's really to look at repeatability of the scan. And that's important for measuring change over time. So we want to make sure the scan's repeatable. And then when you see increase or decrease in amyloid, and you can measure that over time, whether patients are progressing or are potentially getting better. Muriel can share this information. This study is still enrolling. There's this independent SMO that's taking in patient triage. So this is a phone number and email. The study is being conducted in the Bay Area, San Francisco Bay Area, but we do pay for travel. So there are patients who are traveling across country as well. And it consists of a injection of the agent and then PET scan approximately 5 hours later. On the therapeutic side, just very briefly, we have 2 agents that one is already in a phase 1, what we're calling biodistribution trial, which is a target engagement trial, and the other will enter relatively soon. So this agent uses SAP. So SAP, for those of you familiar, it's a protein, but it's used now as a scanning technology in London. So this SAP protein is part of all amyloid fibrils, and it sticks very well to amyloid fibrils. We've combined it with part of an antibody called a FC, and the FC is the part of the antibody that recruits the immune system. So it will recruit mainly macrophages, but also potentially neutrophils, giant cells, to come in and engulf the amyloid fibrils. And then our second therapeutic, so these are very unique molecules. They're not kind of pure antibodies. There's been a lot of engineering of these. The second one is what we call an antibody peptide fusion, and this is what a typical antibody looks like. But it also has these peptides that are inserted on the end. And just to say, similar to the way SAP and the other molecule has been used to bind to amyloid and image, these peptides are very, very similar to the peptide that's used in our imaging agent, where we know they are binding to amyloid. And I think that's it for me, Muriel.
Thank you very much.
I hope I stayed on time because I got chastised at the last meeting.
Well, you went 10 minutes over last time, but that's okay. This time you were good. And I do have a quickie question for you. With ATTR, have you seen anybody light up in the bladder?
Yes, but bladder is a place where the radioiodide gets distributed, so you can't tell for sure if that's amyloid. So you see the bladder in almost everyone, including healthy volunteers. So the iodine goes through the bladder.
Okay, and the reason why I asked that, and this is for all of our panelists, is we've had 2 patients so far tell me that they got diagnosed with ATTR because of a biopsy that was taken of their bladder for whatever reason that they needed a biopsy of their bladder, and it was sent to the Mayo Clinic for mass spec and came back as ATTR. So
yeah, I mean, I can give you some examples. I can't tell you how many percent of patients, but we've seen it certainly in the lung in a significant amount of TTR patients, and that's a known phenomena. We've seen it in the adrenal of a couple patients. We've seen it in the kidney of maybe a third of the patients. We see it in the brown fat in some patients, and certainly in the connective tissue. So it's, in some patients, particularly variant patients, kind of a widespread distribution.
Okay, thank you so much. Okay, if we could have all of our panelists now. And we want to thank everyone for their presentations. This has really been great. Okay, this question is for our Intellia, for Dr. Maitland, okay? And I know this is a tough one because you come from the cancer world, and I know you're not up on ATTR variants, but so maybe our other physicians can help you on this. But this gentleman says our 41-year-old son has been diagnosed with the Taiwanese HATTR mutation, ALA97SER. He exhibits no symptoms as yet. He's taking diflunisal. he's not receiving any other treatment, can your, I don't know what to call it, he calls it NTLA 2001, target this mutation? So I guess the question would be, Dr. Maitland, are you able to see certain mutations that you're able to target versus others that you're not able to target?
So it's a good question. Let me not be insensitive, of course, to the patient and the question, but of course, I'm not in a position to give medical advice. I would note that we have been genotyping every patient in the study so far. In fact, we did report that we have 2 patients with that mutation, and they're being monitored in the context of the trial. And I may not have been as clear as I intended on that next to last slide with the crowd and people of different sizes and colors. But indeed, the concept behind choosing the particular location in the TTR gene where the DNA will be removed and the knockout will be generated is a region that's effectively free of all the mutations. So we're expected to be able to knock out the gene regardless of the mutation someone has. And then, of course, if they have wild type, the gene may be knocked out by that method as well. Again, I'm talking about tests that we've performed in the lab, and then just so far 15 subjects in the phase 1 clinical trial. It's early, I'm not making anyone any guarantees, but the concept is that it should be a treatment that would work for all subjects.
Great, thank you. And panelists, if you have any questions of any of these people that we're questioning, don't hesitate to ask, okay? Okay, this one is for our Alnylam. Once vutrisiran is approved, is someone who is on Onpattro eligible? And how easy will it be to change from one to the other? Will people automatically be changed from one to another, or do they have to ask? So that's kind of a lot of questions, but I think it's a lot of questions that a lot of people have. So
yeah. So similar to how a patient would start any therapy, it's the decision of the patient and the physician. So that's definitely the first conversation that needs to happen. And then if the patient and the physician do decide vutrisiran is the right drug, it would then require prior authorization with the insurance company, similar to what they went through with Onpattro or whatever therapy they're currently on.
Okay, and this question while we have you, Colleen. Okay, do they expect vutrisiran to cost more than Onpattro?
I have no information on cost yet, unfortunately. I anticipate we'll have cost information the day we launch.
Okay, and this would be covered under Medicare Part B because you have to go to a doctor's office for the shot, correct?
That's what we anticipate. And again, I think that's something that could be insurer specific. But looking at how they most insurers classified Onpattro as a B drug, we anticipate the same.
Okay. And here's someone that also, do you expect it to be approved in April?
Yes. The PDUFA date is April 14th.
April 14th. Okay. So
it's burned in my brain.
Okay.
Colleen,
well,
could I just ask? I just wanted to ask you, there are drugs that are administered by patients sub-Q at home, self-administered. Any thoughts about that as a potential?
A lot of discussion has happened. At this point, there are no plans to offer at-home administration.
Okay. My husband is on Vindamax. Okay, this is for our Pfizer people. Oh, never mind. Okay, it's okay. Here we go back to Intellia. Do you think CRISPR can be used to treat the damage to the retina and maybe the optic nerve caused by hereditary TTR and neuropathy? I think that probably because you're working on, there's another, disease that you're working on that involves the eye. Maybe that's why that question came up.
It's a good question. The current model for treating diseases of the eye is to inject a CRISPR-Cas9 carrying agent directly to the retina. So I think it's too early to tell whether a systemic treatment, right, one that's getting into the body by IV, would be of help. I think the key point is that for NTLA-201, coming in a lipid nanoparticle, effectively all of the drug is going to the liver. So we would not be expecting that we would be editing the gene in the nerves in the retina. The idea would be similar to with vutrisiran, for example, reducing the circulating TTR would reduce further injury to that region of the eye. And we'd be relying on natural body processes to remove the amyloid and allow slow recovery of healing if that's possible.
Okay, this is for our Ionis person. We know that Onpattro, well, actually they call it Onpattro, but we're talking about vutrisiran, will be approved in April. When do you expect your drug to be approved?
Thanks, Muriel. So as we said before, I think Ionis is, chronologically speaking, for the polyneuropathy trials from Alnylam around 6 months to 9 months. So we will be having the interim analysis now in the second semester. And if it's positive and if it's doable for a submission and a launch, I would suggest maybe first semester of 23. So that would be plus or minus our plans now. Hope for the good results as Elios A presented.
I don't know. I think this is more for our cardiologist than it is for our advisor people. How will we know the Vyndamax is working?
Yeah, that's, like I said, a very important and common question that patients ask. A lot of us appropriately, I think, rely on the evidence from the clinical trials, but when following a patient, most importantly, we talk to everybody, trying to figure out if their symptoms are present and progressing, God forbid, or stable. We look at, as we talked about, biomarkers or blood tests. Notably, we at our center measure prealbumin levels to show that with stabilizers, prealbumin levels go up. We measure functional capacity, sometimes hall walks, and then there are, the cardiac testing that we talked about. So it's a plethora of things to, determine. This will become, God willing, very important as we begin to develop more treatments across the spectrum of disease that are available. And I have to say, I don't know how clinicians are going to make decisions about, when one's not working and move to another and so forth. We need a lot more research and clinical experience in that regard, but it's an enviable place to be in, I have to say. Better to have many treatments than just, one.
My question is, can spinal bridging or fusion of the cervical and thoracic vertebrae be a cause from amyloid? All of my vertebrae from C1 through T5 are fusing together. When a CT was done back in 2017, there was no sign of this happening. This appears to be very aggressive. My spine surgeon believes that it's amyloid that could be the cause. My amyloid doctor doesn't think so. So what are your thoughts on that, since we have you on the screen, Dr. Maurer?
That's a very unusual thing for amyloid to do. So I would say that it's probably not the amyloid that's doing it. There are other diseases that will fuse the bones like that.
Okay. My question is concerning symptoms from V122I. I just completed a neuropathy test last January. I have tingling in various places like face, legs, arms, and fingers, and my feet. The doctor told me that only 1.6% of patients with V122I experience this. She didn't, wow. And also I've started having gastro issues. All right, so let's get to the V122I, which is known to be cardiac involved. And this person is listing a whole bunch of neuropathy stuff. Do you see a lot of neuropathy with the V122I?
So this is a subject that's near and dear to my heart, as Matt knows. I have been harping on this for a very long time. V122I does indeed cause a neuropathy. It is mostly a cardiomyopathy disease that causes a heart problem. But in a large percentage, maybe more than 10% of people will have a neuropathy, and sometimes they'll just have a neuropathy without having a cardiomyopathy. And I have a few of those patients whose family members actually had a cardiomyopathy, but they don't have a cardiomyopathy, they just have a neuropathy. So it is indeed neuropathy can be a manifestation of V122I, hereditary amyloidosis, and it should be looked at very carefully and possibly treated.
So do you have some V122Is that are on Vindamax and also on Onpattro?
Yeah.
Okay.
On Onpattro and on Tegsedi, both.
Wow.
Yeah, I just wanted to
Tegsedi
comment.
and Vindamax, or Onpattro and Vindamax. We want to be clear that it's not Onpattro and Tegsedi.
Correct.
Okay.
Correct.
Dr.
Yeah,
Marr?
I would congratulate Sami for focusing on this all these years, and he's enlightened us. I think there's been if I had one thing I'd like to do over in the field of amyloid for either regulatory or clinical reasons, we've ended up separating this disease out into neuropathy and cardiomyopathy. And as a lot of people are talking about today, we see that therapies are being developed across the spectrum of diseases. We see imaging agents that can identify disease in multiple organs. So, I think part of it was because, if you have me as your cardiologist, you're in trouble if you want a good neuro exam. And I could not pick up on some of the subtleties that are happening, but there's a lot of autonomic dysfunction as well in patients with V122I. And, if I had one thing to do over, it would be to change the system that we've made up in the approval of drugs, and how we treat patients, because it really does require a whole team of people to kind of engage. And I think we've oversimplified the disease a little bit by segregating it.
Absolutely. We'd like to shoot the person that came up with FAP and FAC and just call it, we're all with you on that one. Okay. And then if you Google FAP or FAC, you see it could relate to entirely different diseases. So there you go. Okay. Here's a question. Someone who has their family has the Val30 met. This person is not yet symptomatic or doesn't think she is. And she wants to know, if present, can amyloid deposits be felt? An example would be during massage, the therapist finds what they're referred to as fibro bumps. They were pointed out recently in the forearm without having a diagnosis of fibro. Could something like that happen? The thought was triggered from that recent article about skin biopsies, usually taking the nerve fiber samples, but they also mentioned sampling from the wrist. So what are your thoughts on, can amyloid deposits be felt?
So usually no. This is a thing that you see. These are changes that you see under the microscope. So they're really tiny, tiny, tiny things that are changed the tissue. So you can't feel it.
Okay. Are there, okay, this is for you, Spencer. Are there any plans for expanding the imaging study to other locations?
Yeah, not for the current study because it's relatively small. So it's only 20 to 25 patients, and it is filling up relatively quickly. We do have spots open, so I do want to make that clear. But I would, if people are interested, I would contact that number relatively soon. As I mentioned before, we are engaging on a phase 3 trial later in the year, and this will utilize amyloid centers across the country, as well as Europe. So there will be opportunities, and there are some investigator-initiated studies that are going to start a little bit later in the year. Those will be individual institutions, but they are in different areas. I just can't share exactly where those are right now. So there will be opportunities, but for this study, it is in the Bay Area.
Okay, and if you send me the information, if people email me and ask me about the study, I can send them information like I did for the AL people.
Yeah.
I do want to mention that we did invite Novo Nordisk, who has the X4 antibody study, and we've been in conversation with them in the last few months, but they were not ready to present anything as yet. So but they're probably listening in, so say hi. Okay. Can AFib be an early sign of cardiac involvement in asymptomatic carriers?
AFib?
Yeah.
Yeah, absolutely. I mean, I think it can occur early.
Okay. This is a person with the ALA 60 or ALA 80, right? Whoever decided those should vary by 20. That's another person we can line up, right? Okay. It was diagnosed. I was diagnosed with hereditary TTR 3 years ago. Have been on Vyndaqel for 2.5 years. Interested in seeing if I am a candidate on Onpattro. What criteria does one have to meet before starting on Onpattro? My EMG shows moderate neuropathy, feet and lower legs. Neurologist I saw does not treat amyloidosis patients. I also have spinal stenosis, so wondering if my neuropathy symptoms are also related to the diagnosis. Help, thank you. So if this person came to you, Dr. Punnoose, what would you say?
I think from my perspective, if he has neuropathy, then we ought to be considering something like patisiran. Obviously, it's a conversation with his physicians and his teams, but I think that is something to consider. I don't know how other folks feel as well.
Okay, Dr. Sarswat?
Yeah, absolutely. I mean, this is where that multidisciplinary approach is important. And this is where we lean on our neurology colleagues to help us tease apart, are those neuropathy symptoms truly from amyloid deposition, and would that patient benefit, and kind of get their stamp of approval. So, you know, I'd be interested in hearing what Dr. Khella has to say, but absolutely.
I'm sorry, I missed the question. What's the question?
Oh gosh, I threw it on the floor. After I'm done, I'm throwing everything on the floor. But
Like
this
was
was
a patient with cardiomyopathy who had moderate evidence of moderate abnormalities on EMG. Is that correct, Muriel?
right. That's right.
Yeah, I mean, at our place, we usually try to go for a silencer or a combination therapy if we can do it.
Okay, while we have you, Dr. Khella, don't leave. Okay.
I'm not going anywhere.
Okay, I am having vibrations and tremors throughout my body. No one seems to know what is causing these vibrations. I'm having constant pain in my right wrist throughout my body, pain below my buttocks, and problems relating to my GI tract. Now, this is a person with ATTR amyloidosis. Are these symptoms, and they have hereditary, are these symptoms related to the hereditary amyloidosis?
So it's really hard to practice medicine like this. You know?
You can do it though. You can.
No, I can't. So you really have to go see somebody who sees a lot of amyloid and a lot of neuropathy, and you know, they can then make the judgment, is this something related to neuropathy or is this something else altogether?
Okay, and let's go to our Pfizer people. I started tafamidis January 2022. I have an upset stomach all the time. Is there something to relieve the upset stomach? Is this amyloidosis, or is this a side effect of the drug? So what should they do if that something happens? What's the official word, you know, if you have a side effect, or you might have a side effect from tafamidis?
Hi. Oh, yes. Okay. Can you hear me, Muriel?
Yes.
Sorry, we were having a little technical difficulties. So, you know, I'm actually going to default to our physicians for any clinical advice. Can say from a package insert perspective, we don't have any side effects like that that were notated greater than placebo. I will go ahead and notate that from an adverse event reporting perspective. But any of the physicians, if you've had experience with patients with that you have specific advice, I would really welcome their comments.
I would say that it's not an uncommon complaint in my experience. However, it's not related to the drug. If people feel like it is, you know, you can hold the drug for a little while and reevaluate and see. But you know, in the original phase 2 trial that didn't bear out, in phase 3, there was slightly more flatulence and some GI upset, but that wasn't something that was seen more frequently with tafamidis than placebo in the ATTR ACT trial.
And Dr. Khella, here's someone back with the wild type with GI issues. And they say, I am an ATTR wild type patient and recently have been having significant debilitating GI issues. My questions are, there known or suspected GI issues with ATTR wild type?
So there are GI issues with wild type amyloidosis. But I would defer to the cardiologist because they see a lot more wild type than the neuropathy. The neuropathy, especially the peripheral neuropathy, is very mild and is even controversial whether it really happens in people with wild type. It probably does, but the cardiologists see a lot more wild type disease than I do. So I would defer to them about the GI issues.
Okay, Dr. Sarswat.
Yeah, I mean, I definitely see wild type patients with GI issues. I think it's always challenging to tease apart if those GI issues are from true amyloid deposition or from autonomic dysfunction, but we see it all the time.
Okay.
Yeah, I agree, and we're considering this idea. I don't know if of trying to assess this a little bit further. There are these capsules that you can swallow that can actually over a few days assess your GI motility and measure pH in various parts of your GI system and so forth. They're used to assess autonomic dysfunction. And the dilemma, unfortunately, is a lot of patients with wild type disease also have pacemakers, and this tends to occur more advanced. And right now, at least according to the manufacturers, there's an interference from the little pill that you swallow and a potential pacemaker. But that's one idea that we've been trying to explore as a non-invasive way to get a better assessment. The other way people can is you can do gastric emptying studies, but they take forever. And I'm not sure they're specific for amyloid per se.
I see nodding. Okay. And now the next subject is antidepressants. What antidepressants are used for wild type ATTR? And this is people on this person is on Vyndaqel and spirolactone, but I would imagine that this is a good question for everyone, because who doesn't want to take an antidepressant? No one wants to be depressed. No responses here.
I don't think there's any specific antidepressant that's right for any patient, right? I think I've had some reasonable luck with things like Remeron because I feel like a lot of patients lose their appetite, and Remeron can help with that and can help with them sleeping. I do try to engage lots of times our palliative care doctors to try and see their advice if they have anything to offer as well. But Remeron tends to be the one that we go for, but not for any other specific reasons other than that it helps appetite and sleeping.
Anyone have a favorite that they prescribe?
I would agree that Remeron might be more useful. The only caution I would make about the broad spectrum of antidepressants is some of the older ones have changes on your EKG intervals and QT intervals. And so we get a little cautious, especially if people are on other medications. And I would put a plug in for walking and exercise as a good way to elevate your mood.
Okay. And there might be contraindications with the treatment they're on. And also, so we definitely want them to check with their amyloidosis physician before they take any other prescription medications for sure. This person says, and this is for our cardiologist, also husband had AV node ablation using ICD, but still gets AFib. Doctors don't know why. He was told he would not have AFib again. Ventricle still okay from device. Any ideas?
I think unfortunately AFib may be one of those things that's a persistent problem and doesn't fully dissipate with treatment alone. So it may be something that he struggles with.
I mean, I think once you have atrial fibrillation and you have amyloidosis, it's next to impossible to get rid of. The AV node just severs the connection between the top chambers of the heart and the bottom chambers, but it does not get rid of what's actually happening in that top chamber, meaning the atrial fibrillation. So, but theoretically, once you've done an AV node ablation, regardless of what's happening in the atrium, it shouldn't be making a difference.
What is the longest any of your patients have lived with ATTR wild type? Well, I guess you'd have to know how long they had it before you'd know how long they live with it, right? But let's ask you, Dr. Sarswat, what's the longest you've had a patient that's lived with ATTR wild type?
I had a patient who passed away last year that had been in several of the initial tafamidis trials and had been on tafamidis for, about 12 years at the time he passed away. he, in that era, was probably the longest living. I think that is changing, obviously, with our modern treatments, and I expect that a lot of our patients will live that long.
Dr. Maurer, can you top that?
Yeah, we have had 2 patients, unfortunately, who recently passed away, but both were in the phase 2 tafamidis trial. One lived from 82 to 97, so 15 or 16 years, and same for the other, not as old. And we do have one patient who had wild type disease who was in the original TRACK study, which is a natural history study, and got a transplant, and he's alive 15 years after transplant. Yeah, I think long-term survivors are going to be much more common, and we're grateful to our colleagues from the pharmaceutical industry for developing really great therapies.
Absolutely, and tafamidis was the first. It's pretty exciting. Okay, Dr. Punnoose, what's the oldest? I mean, you're kind of young in this business, but we'll ask you anyway.
Well, this is very true. So I can't speak from personal experience, but I do agree that survival is going to change a lot with the therapies that we have. My panel is very relatively new, so I can't really comment on survival times as much.
Okay. Now this person asks, what do people die from? A heart attack or a stroke? If they die from, assuming they're going to die from amyloidosis, we know a lot of people die from other things before they do. But with that said, if you're going to die from wild type ATTR amyloidosis, are you going to have a heart attack or a stroke? What's going to happen to you, Dr. Maurer?
Neither, usually, not a heart attack nor a stroke. It's usually just progressive heart failure and worsening functional capacity. From a patient's perspective, it's kind of inability to do your ADLs or IADLs. You become annoyingly
ADL?
Activity of daily living, dressing, bathing, those kind of things. IADLs or going to the store and shopping. You become increasingly reliant, in my experience, on other individuals. But it's not usually a sudden heart attack. Strokes can happen, but they're relatively unusual, especially if, God forbid, you have AFib and you're appropriately anticoagulated. The chance of having a stroke is relatively small. So it's a slow and progressive decline in one's capacity to function, but not something that's usually sudden.
Okay, we have a patient who's been on Patro for 2.5 years, and he's doing better. Everything is looking good, but he still hasn't gained the weight back that he lost before he was on the drug. So how long does it usually take to gain the weight back, or do we think he will gain the weight back? That would be for Dr. Khella, I guess.
Well, the weight loss in amyloidosis is probably multiple factors, and certainly people who have, advanced heart failure probably have more weight gain than they have weight loss. But it sometimes it's from the diarrhea, sometimes it's just weight loss, and you don't understand why. And there are probably other mechanisms that are involved. And weight loss is a bad prognostic sign in people who have amyloid.
Okay, so now here's another person, Dr. Khella, says, does physical therapy help you? And what about leg or foot drop?
So it's like Dr. Maurer was saying, it's absolutely physical therapy is wonderful. It's good for your head as well as your heart and body.
Okay. Now, I've saved these for last because they're very technical questions. One is from one of our physicians. And I confess to not understanding it, but maybe it'll mean something to some of our people out there besides him. So we'll ask it. What happens to TTR from a normal person when incubated under proper conditions in vitro with serum or plasma from a wild type patient? What happens to the TTR in the serum or plasma from a wild type patient when incubated under proper conditions in vitro with that of a normal person? Rather than relying on the theoretical concept that putatively normal TTR from wild type patients more readily disassociates because of old age, wouldn't this simple experiment cast light on the actual mechanism of the disease? Does anyone want to tackle that?
I had the chance to read it beforehand, so I processed a little bit. I think it's a very great question. I don't think the experiment, to be honest, has been done. I would highlight, though, one comment and then one perspective. One is, I think we should all say the prevailing paradigm of the biology of the disease, not we know what it is that TTR falls apart and dissociates, especially in wild type disease with age. Having said all that, in the original paper that we wrote with Jeff Kelly, developing the TTR kinetic stability assay, which is a measure of how unstable TTR is, no one seems to really recognize, but in one of the figures, TTR was not more unstable in those who had wild type disease than those who were older adults and age and gender matched. And so it's clear that stabilization prevents the progression of disease, but I think the biology of TTR amyloid may be much more common than we ever thought. For example, why is the protein made by the liver but doesn't seem to deposit in the liver? And what is the cause of tissue tropism? Maybe there's particular spots in ligaments in the heart and other organs that attract it there. So I think we have probably a lot more to learn, but I appreciate the expert idea, and I will try to explore it with some basic science colleagues to see if it might be useful.
Any other comments on that?
I agree with Dr. Maurer. I think our explanation of how amyloid causes disease right now is really too simplistic, and it's probably much more complicated than we understand. And there's more to be said about this for sure.
Okay. Another question. We're getting towards the end, and of course we're late. This is Muriel, right? Okay. I don't know if this can be answered. Can anything be done to accelerate the process to get necessary treatments after diagnosis? Is there a delay in that for hereditary TTR? Is there a delay in getting someone to treatment after they're diagnosed? Do you see that, Dr. Khella?
Only if there's a problem with the insurance. I mean, you know, once you get to somebody who knows how to treat the disease and can think about your particular problem, it really becomes a matter of just the logistics of getting the medicine administered.
Okay.
I would add that I do think there's a problem. I think, you know, despite everyone's efforts and the financial assistance program and Muriel to everything that ASG does, it is pretty complicated. And it takes patients a long time to fill out the forms and get their, tax documents together, and people who are not, I think, so savvy, it's taking them a lot longer. And I fear that there is a disparity with regard to socioeconomic status and education with regard to how quickly people access drug. We have some preliminary data to support that. And I think the Amyloid Research Consortium does as well. And so in the realm of health equity, I think we really do need to focus on that in the future.
Hey, Muriel, can I just add one thing?
Sure.
This is more related to AL, but I've done a lot of research on this in the AL, and assuming that's similar in TTR, that when people get diagnosed in the community, at times it does take, not just on the insurance side, time to find someone, the right person to treat them. And certainly if they get diagnosed at the centers that are involved here, they can go through to that process quickly, assuming insurance plays. But if they get diagnosed in places that just don't see a lot of amyloid patients, it can take time to get to the right place for treatment.
Very good point. Before we say goodbye, and I want to hear from each of our physicians, maybe some final words to our patients out there. And I know, Dr. Punnoose, you have to leave, so we'll hear from you first. Any final words to our patients out there? We still have 211 hanging on.
Well, I am very grateful for the opportunity to share in this knowledge and speak with the panelists about this course. I think there are a lot of resources, especially through this group, and I hope very much that everybody continues to learn as we go forward.
Thank you. And Dr. Maurer, what do you have to say to the group?
I just echo the sentiments. I think ASG is a fantastic support for patients. We're unbelievably fortunate to have you guys advocate on behalf. And as everyone knows, there's probably not a lovelier group of people in the whole world than patients with amyloid. So it's a pleasure to continue to help take care of them.
Oh, that's sweet. We weren't looking for that, but that was really nice. Thank you.
I would say amen to that.
Oh, wow. No, we wanted you to give the patients something. Thank you. Dr. Sarswat, do you have anything to say?
No, I would say that I always enjoy every time I'm on a panel like this, because I learn so much from patient questions. I learn so much from my colleagues. I think it's just a wonderful thing. I think it's a great, ASG overall is a wonderful resource for our patients. I wish that all patient, especially rarer diseases, had groups like this that they could really turn to.
Thank you. Okay, Spencer, any parting words to our group out there?
No, just thank you very much. And it's nice to see some familiar faces I haven't seen in a while. So thank you again, Muriel, for your time, and echo that this group does an amazing job for patients.
Oh, thank you so
Nice
much
to
for
see
the
you,
kind
Spencer.
words.
Good. Yeah, I was looking at you when I said that.
Dr. Maitland, any final words?
I feel like a rookie, but very glad to get familiar with all these folks and look forward to engaging further with the patient and the clinician community. Thanks for having me.
Oh, you're welcome. And I may be sending questions to all of you that haven't been answered, so be prepared. Okay, Lori, any parting words?
Muriel, just great to see you. Great to see all of you guys again. And thank you for this opportunity. We look forward to the day when we can gather and be with three-dimensional people. So looking forward to that. So thank you.
Absolutely.
On behalf of both myself and Abbas.
Oh, absolutely. Thank you. And Gustavo, any parting words for you?
Thank you very much for having me here. It's always a pleasure to be here. Hope to be back in the future with more great news for the patients. Thank you.
Thank you. And Colleen.
Yeah, thanks for having us, Muriel. I just want to put a plug in for two roles that are within our organization, and I think every drug company has a version of these roles. One is the patient education liaison, and those are genetic counselors and nurses that are out there talking with patients about what to expect when therapy is prescribed and educating on the disease. So just know that resource is there. And then the other resource, which I think is so valuable, are the case managers that sit behind the phones at Alnylam Assist, and again, every company has that version. I'm not remembering what the names of the other ones are, but those folks are there for the patients. They're there for you to help you navigate that challenging process of getting coverage. So use them. They're there to help.
Thank you. You remind me, the Vindalink for Pfizer and their PfizerPal.com, and absolutely, they're all wonderful, and the patients tell us how wonderful they are. So thank you so much. And Abbas, do you have any parting words to our group here?
No, honestly, I'm humbled to be part of this august group, and really, I was just taken away by how informed the patients were, and the only thing that I can say is, for the patients and for ASG, keep on advocating. If you keep on advocating, change will happen.
Oh, we're not going to stop. Nothing's going to stop us, right? We're going to keep on going. I want to thank our entire group. I want to thank all of our patients for taking part in this. Make sure you fill out the survey at the end of the program today. It's going to be so helpful. And I will be sending out an email to you doing a summary of today's program. And also Bob will get this up on our link on our website and also on our YouTube channel. So we look forward to seeing you again soon. Take care, everyone.
Bye-bye. Thank you so much,
Thanks,
everyone.
Muriel.